Good morning. We are the team Karatotech. Today we want to talk about a silent challenge affecting the vision in the most vulnerable regions of Peru. We want to talk about the detection of keratoconus, especially in rural areas of Arequipa. But first, we want to talk about this problem, the keratoconus. The keratoconus affects these young adults at the average like 21 years, and to take, especially for the rural areas, is a simple eye exam. It took like 12 hours of travel for this only reasons. So this is a one big problem because they can access a normal attentions in the primary hospitals. So we have that this prevalence, like the 80% of the diagnosis is located in rural centers, for example, like Lima. And the other problem is that this kind of late diagnosis, because near to the 98% of the patients is already advanced astigmatism by the time of diagnosis. So the last phase of the keratoconus is the cornea transplant. That if you want to access of this kind of therapy, for example, the beginnings, the first and the third phase is the cross-linking, but they can access because the dictation is not in time. So for the cornea transplant, that it high cost for $4,000 or more is also for a limited access, especially for these rural areas. So we want to have a real solution because the other problem is the kind of infrastructures of topographers or equipment that is really useful for the detections. So first is located in the principal cities in Peru, like Lima, Arequipa, or Huancayo. However, this kind of people can access because these equipments that is only one or two on this kind of cities, it has a cost of $10,000. So it's like high power, and also you need another personnel to attend this kind of technology. So we want to be more access to this kind of technology, obviously first for one kind of detections and also for this kind of treatments, do not tweak for the cost of this cornea transplant. So this is our solutions. It's called Keratotech. It's a portable and hand designed optimized for field and community use. We want to focus that it's not only used for the ophthalmologists, it also we can use for the medical, other kind of technicians. On the other hand, we have this accessible cost because it costs over that $2,000, and this is a smart integrated algorithm for immediate correct conus screening without needing a permanent internet connection. Especially we use this nude screen, and also we want to use these kind of USB connections, and we don't need the internet to take this exam because here in Peru, in this kind of rural areas, don't have the access of internet, and also don't have a good signal to upload some kind of documents. So this is also hardware and software.
Okay, so we have designed a 4-step ecosystem, starting by local screening, then having the secure synchronization, the specialist review, and patient notification that will get to their phones. We are trying to transform 12-hour journey, like we mentioned before, into a seamlessly digital flow. So also it's important to notice that we cannot negotiate with the accuracy of our device. So our preliminary validation against the Pentacam, that is considered a gold standard, shows impressive correlation. Our clinical parameters like K1 and K2 and KM are almost similar, proving that Keratotech delivers high fidelity data. Also, to be a sustainable device, we're focusing on direct sales to the Ministry of Health, that is called MINSA here in Peru, to equip primary care centers from level I1 to I3. And also we're trying to count with production cost under $200, like we mentioned before, and a target price of $600, scaling across with the National Health Network. Our roadmap is really clear. We look forward to start with clinical trials to validate the device's performance, then go on with the certification process that has to be validated with the HEMIT to comply with national medical device regulations. Then we want to scale the solution within the next 12 months. We plan to launch not only in Arequipa, but also other rural areas that need this attention, and expand access not only to Peru, but also get to another countries like Bolivia and Ecuador, where similar barriers in this area exist. So we want to present also our team that is confirmed by me, Wendy Chavez, Violeta Vilcapoma, Rodrigo Chuquillure, Alejandro Ecos, Isabel León, and Gabriela Sánchez. And finally, what do we need is funding to finalize and validate our product. Also, we need support for clinical trials and field deployment, and we need regulatory mentorship from the EMID. And this matters because early detection can prevent irreversible vision loss, and millions, like we mentioned before, lack access to corneal diagnostics in rural areas in Peru. Thank you very much.
Awareness. I'm just curious, you mentioned partnering with NGOs to launch sort of a massive campaign. Have you seen that strategy effective with other disease states within your region?
So we've been, when we did the research, most of the times it works, obviously, but we need to make like a protocol to apply it. Otherwise, it probably won't work among people because sometimes people is not available to do these kinds of campaigns. So it's important that part of the protocol is teaching them how is it going to work with them. Otherwise, they probably will show resistance against working with this kind of device because it's also something new for them.
Yeah, and the other point is especially obviously the language because here, well, in the most cities in Peru, we speak Spanish. However, in these kind of rural areas, you speak Quechua and Aymara. So this is really important co-working for this kind of governmental relations that is, for example, in Arequipa or in Puno, in those kind of these cities, because this is kind of cooperative work. So this is our protocol is focused also includes this reality.
I know you said in your future plans you're going to do more clinical validation. I wonder what data set you used for the preliminary results that you showed, how you were able to see that your device seems to work compared to the gold standard.
Yeah, the problem is that we now need to be accepted to the ethical committee here in our university, and also we use like a group of students that is obviously our team and one other partner that has this pentacam exam before. So we obviously like use like a calibrations for our software. So we have this kind of data. We use like 10 or 12 students to work with us in this opportunity. We obviously needs we need keratoconus patients because I think that this is really important for us, but we need to have this bureaucratic thing.
It's important also to mention that when we did this test with Pentacam, we did this project as a part of a course. So the students that helped us were actually also part of the course, and we were all developing similar devices. So our professor actually helped us with working with INO, that is the Institute of Ophthalmologics here in Peru. So they allowed us to use the Pentacam and obtain those exams to compare it with our results so we could validate.
We are Team Ankle Glide, and today we are presenting our device, a continuous ankle flexion device for long-term bedridden patients. And our goal is to prevent deep vein thrombosis and muscle atrophy through affordable physiological ankle movement. Here is a picture of my team. We are some students from Bangladesh, and our project mainly focus on solving a real hospital problem we observed in low resource clinical settings. What is DVT? Deep vein thrombosis is a serious but preventable complication of immobility. When patients remain bedridden after a stroke, trauma, surgery, or ICU admission, blood begins to pool in the deep veins of the cuff. This can form some clots. If that clot travels to the lungs, it can cause pulmonary embolism, which can be fatal. The dangerous part is that DVT is often silent. Many patients show no symptoms until it becomes life-threatening. And in Bangladesh and similar low resource settings, many patients stay immobile for weeks. Nurses may perform manual ankle movement, but in overcrowded wards, they simply do not have always time. So a preventable complication becomes a life-threatening one. Um, Points to be mentioned that there is less than 2 ICUs for 100,000 people in Bangladesh, and over 67% of DVT cases in low medical resource settings go undetected or untreated. And if we look at the access gap, we see that the government hospitals in Bangladesh do not have access to compression devices. But in the high resource settings, DVT should be prevented by sequential compression devices, physiotherapy sessions, and monitoring. But these options are expensive and often unavailable in low resource settings. The compression stockings depend on compliance. Sequential compression devices are mostly need disposable garments. Commercial continuous passive motion devices can cost hundreds of thousands of dollars, so the access gap is clear. The patients who need preventive movement the most often have the least access to it. So here comes our solution. Our project Ankle Glide. Our Ankle Glide is a low-cost reusable ankle flexion device. It provides repeated ankle movement to activate the calf muscle pump and improve lower limb blood flow. We have focused on mainly 4 parts: the physiological effectiveness, the low cost and reusability, caregiver-friendly operation, and bedside practicality. Uh, our device, here is a quick GIF of our device. We can see that the ankle is being moved by dorsiflexion and anteroflexion in dorsiflexion ankle and plantar flexion position. Um, If we look at how this works, the foot secured on the foot plate, the cycle count and speed are entered by a keypad. The Arduino controls the whole process, and mainly we have 2 high power servos which controls the dorsiflexion and plantar flexion motion, and it increases the venous return by activating the calf muscle pump. The range of motion of the device is -10 degrees to the +31 degrees, and about 20 to 200 cycles are can be given as input. Here are more of our devices. You can see in the low resource medical settings. To check whether the device actually improves the lower limb blood flow, we performed an early Doppler ultrasound evaluation. We measured the popliteal artery blood flow in one healthy volunteer before and after using the ankle glide. We can see the significant changes and increase in the blood flow, as the baseline velocity was 26.2 before using the ankle glide, and after 100 cycle it reaches up to 88.2 centimeters per cycle. So this was our main success. And if we compare our devices with existing options, we can see that unlike compression stockings and many compression devices, it creates active ankle motion and supports the calf muscle pump. Unlike commercial CPM devices, it is much more affordable. Our current cost is approximately $105, making it more usable for local manufacturing and low resource hospitals. But our device is not out of limitation. We have many limitations. That is, we have no battery backup still, and the device is powered mainly from the AC outlet. So no smart sensing or auto adjustment is still introduced, and we have a bulky platform and limited clinical validation. But these limitations are not weaknesses only. We clearly define our next engineering steps from this. Our future goals include the battery integration and pressure and EMG sensing, so that the calf pressure can be sensed and the cycles can be auto adjusted per patient response. The compact bed mount design and multi-center clinical trial and industrial manufacturing. So to conclude, ankle glide transforms a simple physiological motion into an affordable and scalable solution for DVT prevention. Our vision is that no patient should survive stroke, trauma, or ICU care only to suffer from a preventable clot because the hospital could not afford the right device. So with your support, ankle glide can move from prototype to clinical validation, from one device to many hospital beds. Thank you very much.
Can you paint a picture for us of the patient use a little bit more regarding, I assume that you'd need 2 devices on one patient. And is this for somebody that's at sleep postoperatively or in a hospital state that's trying to sleep in a bed? Or is this in the operating room that you picture the use of this device?
No, this is not in the operation room. It's mainly in the ICU bed. The device is attached to the ICU bed, and the patient with long-term bedridden patients basically use it. Here is the picture, some GIF you have asked to show me. And here is also another picture.
2 quick questions. I think the earlier judge wanted to confirm that you'd use this on both feet and on one side. And 2, you mentioned along the way that you measured flow in the popliteal arteries. I want to confirm that that was a misspeak, that actually measuring the popliteal vein or veins, because you're trying to prevent venous clots, not arterial clots.
We have done this as per the directions of our supervisor, because the main idea was that our blood is being carried from heart to our leg through artery, right? So if we can prove that the blood velocity is increasing towards the artery, that means blood is getting from the heart to our leg. So we can say that the total blood the blood supply has been increased, and also so as the return. And also the research paper we have tried to follow before, the idea basically also said that this should be measuring from the arteries. So that's why we have concluded is our conduct our experiment on the artery. And also another question, and another question you have asked. Yes, this will be first placed on only one leg, and after after the cycles are finished, you can just place the other leg and just continue the cycles. It is not built for only one leg or only one side of leg.
Imagine a child fighting a high fever hooked up to an IV drip, and the only thing standing between life and death is whether a nurse notices the drip rate is wrong. Today we present BioDrip, a low-cost automated IV infusion device for precision control in dengue care. Dengue fever is a massive global threat. While it affects over 90 countries, our Asia carries 70% of that burden. In 2023, my home country, Bangladesh, faced its deadliest outbreak. But here is the heartbreaking part. Many of the deaths were not caused by the disease itself, but by the mismanagement of IV fluids. Our hospitals are overburdened. Nurses are stretched thin. In a busy dengue world, manual IV adjustment leads to human error. Our device provides real-time monitoring, automated adjustments while keeping the environment contamination-free. It offers an affordable alternative to traditional infusion pumps. This brings high-quality care to rural areas and reduces the monitoring burden on our healthcare workers. Our inspiration came from Dripplemeter, an open-source IV infusion device. It could only monitor the flow rate, but couldn't regulate the flow. BioDrip takes that idea further. We don't just monitor, we control.
Thanks, Nanjiba. I'll take you through the solution we engineered, a low-cost IV infusion control device built for real clinical constraints. What you are looking right now is a compact 3D printed box mounted right onto the standard IV stem. No complex installation, just keep it on and let it work. So how does it work? We use a simple but effective laser-based system for drop counting. A red laser light aimed at a sensor. Every time a drop falls, it breaks the beam, and the system counts it instantly. Here comes the controlling part. A stepper motor rotates a screw to compress or relax the IV tube, and a Hall effect sensor gives the system a precise positional feedback. Now, the fuzzy control algorithm uses force and fine adjustment technique to regulate the non-linear flow. Here is our working prototype. A healthcare professional says the flow rate in drops per minute. At first, you can see there is no flow on the IV chamber. Now you can see that the motor is adjusting its way to increase the drop count. You can see the drop is being adjusted. There is flow through the IV chamber. Now the DPM has almost reached its. Now you can see that the DPM is almost reached its target, and the motor is locked on the target. There is a slit in the enclosure that lets the IV tube to pass through without any compromising the sterility. Without it, adjustable mounting mechanism. The unit clamps to any standard IV poles, and an integrated UPS keeps it running through the power cuts. Over to Rahim.
Okay, thank you, Abid. Now moving to validation, we tested our drop counting accuracy across the full clinical range. Manual counts and sensor readings matched perfectly across every tested flow rate. We further validated the results using fluid weights, applying a standard 15 drops per milliliter conversion from according to our national dengue guideline. The lab measured weights showed near perfect collinearity with theoretical values, confirming volumetric accuracy as well. Next, we have results showing flow control performance across targets from 220 to 250 dpm. In each case, the fuzzy controller successfully converged within a 3% error band. Overall, the convergence, as you can see, in most cases was achieved in under 40 seconds. Now, further long-term stability tests were also run, and it confirmed that the controller was able to maintain the target rate without a significant drift after achieving the rate. Now, compared to the competitors, our BioDrip is the only device that is offering a full combination of real-time feedback, full automation, and more importantly, affordability and portability all in one. Our total production cost is under $40 with an estimated market price of around $6, which would be much cheaper than the conventional pumps used in the market. For our project, the current limitations include comparatively higher settling time in case of very low flow rates and use of non-industry components, and we are still yet to run a hospital trial.
Looking back, our low-cost device provides flawless drop detection and flow regulation. Our next step is feasibility testing and collaboration with potential partners. All three of us are third-year undergrad students from a South Asian country named Bangladesh. And we believe that precision in healthcare should be a right, not a luxury. That's all from our side. Thank you, everyone.
My question is around sort of the redundancies built into the system. So a lot of these infusion pumps require alerts if there's air in the line or there's a kink in the line. How does your system accommodate those kinds of circumstances?
Sorry, we didn't get that. Can you repeat the question?
Sure.
Can you repeat about the circumstances part? Which ones are you asking to be covered?
I gave a few examples of what would alert an infusion pump that's commercial here in the US, like air in the line or if there's a kink in the line. How does your system accommodate circumstances like that?
Okay, what we are doing is we are using it along with a conventional gravitational drip setup. So we have an alarm that will detect when there is when the system doesn't detect any drop, that is no flow occurs for a significant time. So alarm setup, and so that the nearby practitioners can come and attend.
Thank you, guys. You mentioned a 40-second conversion time onto your target drip rate. So how does 40 seconds compare to competitors, and is there any risks associated with that amount of time?
We haven't yet compared it with the results of our competitors. However, I think and we think there is no problem, because whenever we are adjusting the flow rate, we always start from a precise closed position, so that initially the pipe is fully pressed again, so that no overflow occurs. It takes a time of adjustment, as you can see, 20, 30, 40 seconds, and then eventually goes to the target rate. So the main problem that we need to tackle is over-infusion. So that is easily prevented.
My name is Keith Tongi.
And I'm Ebi Larry.
And we are Team KE Health, and our product is the hemodrop detector. Postpartum hemorrhage is defined as losing more than half a liter of blood within 24 hours of childbirth. It is a very common problem globally, affecting about 14 million women annually, 70,000 of whom succumb to the problem. A majority of them come from low and middle income countries like our country, Kenya. Allow me to paint you a scenario. Our patient here is called Mary. She is a postpartum mother with a clinical history that indicates a risk of postpartum hemorrhage. She goes to a healthcare setting or healthcare facility where the nurse in charge is overwhelmed, has too many patients to tend to. By the time the nurse gets back to Mary, she has lost a significant amount of blood. How does this nurse determine how to what amount of blood is lost? She does a visual estimation and weighs the pad. Both are very inefficient methods of weighing, assessing the blood loss. We unfortunately lose Mary as a result. From the picture I've painted, the challenge that you can see is that we have a strain system. The staff is overwhelmed, and the methods we use to detect postpartum hemorrhage are largely inaccurate.
So this is the motivation behind our solution, Hemodrop Detector. Hemodrop Detector is an automated, suction-enabled monitoring system that is designed to deliver continuous, objective, and real-time measurement of the total blood loss, as well as the rate at which it occurs. It addresses critical gaps in PPH, the first one being detection and also monitoring. So our design criteria, we designed this product to fit in the current clinical workflow, to be able to quantify blood loss with a margin error less than 5%, to have real-time rate monitoring and be cost efficient. So how it works is blood is first suctioned from a specialized pad, and then it's channeled into a canister where it's weighed and it's converted to volume and also the rate of flow. Then the data is then displayed at the bedside unit, which is a hardware, and also at the central monitoring unit, which is preferably at the nursing station. So two things to note here is we have intelligent alerts and also trend analysis for our device. So here are some of our success and limitations. Number one, and the most important being trend analysis and rate of flow. So with this, we will be able to catch abnormal trends before escalation and also monitor improvements. Why this is important is because the current methods being used will be able to determine the patient at risk after the patient has already presented physical signs like lost a significant amount of blood or is already having a very high heart rate or going into hypothermia. So that is always too late. And the second success is accuracy, and thirdly, real-time monitoring. So some of our limitations we have is accounting for the blood clots because it's suction, the blood clots may remain on the pad. And second is we foresee regulatory complexities because our device is multi-component. Thirdly is the technical limitations that comes due to a bulky system and also pad fluid retention. So far our product has undergone two phases, and the first phase has validated the clinical logic. So in our second phase currently, we are addressing the phase one gaps that were patient mobility that came with the bulkiness of the system and also the pad fluid retention. So in our second phase, what we are using to measure the loss is a capacitive way of sensing and and we are also miniaturing the device. So here you can see that we have a graph that shows we have already tested our sensor pad, and we have a high correlation of about 94% between the sensor pad and the fluid being detected. So here you can see that this is the first image shows our bulky system that had a hardware, the specialized pad. And the second system, we have just two important things being the sensor pad and the control unit that will be at the waist belt. And down there we have an experiment that we ran to be able to determine the graph for testing that I showed you before this slide.
We are looking to achieve a sustainable and scalable business model, which will be arrived at on 3 prongs. Number 1 is upfront hardware sales. Number 2 is recurring consumables. And finally, we hope to include an optional value-added services provision that will long-term hopefully subsidize the hardware sales and the consumables. Our market potential is significant. About 1.8 million mothers in Africa are diagnosed with postpartum hemorrhage annually. And the consumables they use to diagnose postpartum hemorrhage are estimated to cost about $3 million.
So since we have already validated the sensor logic of our sensor pad, we are currently raising funds so that we can be able to purchase instrumentation and also medical grade hardware. So this will enable us to move into this next step, which is high bench validation, where we'll be testing for accuracy and a real body physical pressure and movement. And then after that, we will integrate the belt so that our system is fully mobile. Next, we are going to get feedback using our full system we'll get feedback from the nurses and the healthcare practitioners on the ease of use. And finally, we hope to get to the pilot study where we'll be using it in real time. So as Hemodrop, we believe no mother deserves to lose their life while bringing another into this world. That's why you're addressing the biggest PPH gap, which is visibility, and this will enable clinicians to be able to make decisions faster and also save lives. So this is our team. My name is Ebi Larry, a biomedical engineer, and here my partner is Kate Tongi, a medical doctor. Thank you.
How does your device accomplish estimation of blood loss when it exceeds the amount that can be absorbed by a pad?
So during delivery, it's easy to monitor the blood loss and intervene. What we are looking to address here is the invisible blood loss that occurs after birth, which is a very big challenge in our healthcare setting.
Yeah, you mentioned the challenge of clots as opposed to blood flow. Can you say more about that? Because in my little experience in obstetrics, a lot of bleeding actually comes out in the form of clots.
Okay. So first, we mentioned the challenge of clots because in our first phase, we were suctioning blood from the pad, so a lot of clots will be retained in the pad. But moving to this next phase, we have addressed that because when here we are using capacitive method of sensing. That means anything wet, say the blood being so heavy, will be accommodated because when the blood is on the pad, it's still wet, and this mechanism, it's more like it's an electrical field that goes right above it. So it's it doesn't make contact with the pad, but when the pad is on top of the sensor and the field, that means it's within the electrical fringing field. So any blood or anything that is wet that comes in contact will be accommodated for. So the ions of the blood or the ions of the clots are going to show up, are going to be accommodated for.
We are Team Reflex. Today we are here to present our project, a low-cost 3D printed hand exoskeleton for rehabilitation of post-stroke patients. Imagine losing the ability to move your hand, unable to hold a cup, button your shirt, or even feed yourself. This is the reality for millions of stroke survivors. Stroke damages the brain, disrupts motor pathway, and leads to both upper and lower limb impairment. And around 15 million people are affected by stroke every year, and up to 80% survivors experience significant loss of hand function. So, after surviving a stroke, many patients from low-income backgrounds are unable to receive proper rehabilitation. This is because existing rehabilitation devices are very expensive and
therapy is mostly hospital-based. Over 70% of strokes occur in low and middle-income countries, but only a small portion, less than 50%, receive proper rehabilitation therapy. As a result, many patients are left with permanent impairment. So it is not just a problem, it is a global concern. To address the rehabilitation gap, we aim to develop a device, a hand exoskeleton that is affordable and accessible to all, especially for patients from low-income backgrounds. Actually, full-body exoskeletons are often very costly. So we focused on a hand exoskeleton so that patients can at least regain essential hand functions for daily tasks. We have designed our hand exoskeleton using a patient-specific approach. First, a post-stroke patient's impaired hand was measured, and based on this, the exoskeleton arms were designed about 0.5 centimeter longer for proper fitting. Our design features 13 degrees of freedom, almost like a natural hand. It has a linkage-based actuator mechanism with a 2-to-1 gear ratio, which ensures higher torque. The model was designed in SolidWorks for easy customization. This is the CAD model of our prototype. We implemented a rotary encoder-based control system for simple and user-friendly operation. All customized CAD parts were 3D printed using PLA with 50% in fill, making the device lightweight, low cost, and easy to fabricate. Here are the key components used in our system. All components are easily available in local markets, even in low-resource region. The total cost is around $20 and making the device affordable for low-income background patients. Now let's look how our device works. The system operates in two modes, manual control and automatic therapy. The modes can be switched using a push button. In manual control mode, the device functions as an assistive system. The user rotates the rotary encoder and the exoskeleton moves accordingly, resulting in controlled finger movement. In this way, patient can easily grasp any object. In automatic therapy mode, the device functions as a therapeutic system. It continuously performs repetitive opening and closing motion that stimulate neuroplasticity and help in rehabilitation. So our device can function as both an assistive and a therapeutic system. To understand the impact of our device, we compared it with existing hand exoskeleton, including 3D printed, soft robotic, and metal-based system. Although this existing exoskeleton offer some advanced features, they are very expensive and require industry-level fabrication. Their cost ranges from $100 to $11,000, which is far beyond the range of low-income background patients. In contrast, our device costs only around $20. It is lightweight, simple, easily customizable, and can be easily fabricated in low-resource settings. To evaluate the device, we tested it with a post-stroke patient with unilateral impairment. In manual control test, the patient successfully grasped various objects by rotating the rotary encoder with the healthy hand, which enables controlled finger motion. This demonstrates that our device can effectively function as an assistive system. To evaluate therapeutic effectiveness, a month-long therapy was conducted with the patient. The patient used the device for 20 to 30 minutes daily on automatic therapy mode. The patient's finger range of motion was measured using a goniometer before and after taking the therapy. After taking the therapy, after 1 month, significant improvement in finger range of motion was observed across all fingers, as shown in the graph. This demonstrates the effectiveness of our device in supporting hand rehabilitation. In summary, our system is affordable, can be manufactured for only $20, also accessible for low resource settings. The device is also functions as both an assistive and a therapeutic system. It is lightweight, wearable, portable, and convenient for daily use. It is easily customizable and suitable for home-based use. Additionally, our design is open source with proper license. We have shared our work through GitHub, GitHub, and a YouTube video, also published a research paper so that anyone can access and further develop the system. Like any other system, our device has some limitations. The current design has limited mechanical flexibility. It also shows reduced grasp precision. In addition, it is less suitable as an assistive device for patients with bilateral impairment. These limitations guide our future improvements. Moving forward, in future, we plan to optimize the system and explore integration, along with remote rehabilitation and digital monitoring. We also aim to conduct expanded clinical validation. Finally, our goal is scalable manufacturing, enabling mass production for low-income patients worldwide. These are some achievements of our project. This is our team. So, with our device, we aim to make hand rehabilitation accessible and help restore independence. From disability to independence at a cost anyone can afford. Thank you.
Can you clarify, you somewhere in the presentation you mentioned about customization. Are you looking to customize each of the reflex for every patient that gets this?
Actually, it varies based on age. Yeah, if we design 3 prototypes for children, adult, and old patient, it can be fit. Actually, human patients' hand length varies based on age and regions. The mainly the phalanx length varies. We have measured the phalanx length, and according to this, we have designed our exoskeleton arms. In SolidWorks, we can easily customize the phalanx length, and I hope we can easily customize the device, patient-specific design.
It looks like there's other players in the market that are trying to do something similar in focusing on delivering an inexpensive device, like I guess the U Bionic. What novel insight do you say that yours is deploying that actually gives you this upper hand and being able to make something so inexpensive compared to the other market players?
Actually, our device is low cost. Mainly, it is the main point, and also it can be locally fabricable. We actually need a 3D printer, and all components are easily available in local electronics shop. So it is not based on industry level fabrication, and it is also low cost. So anyone can afford it and can be manufactured locally.
Hello, everyone. My name is Hilda, and I'm representing Team Mavericks from Malawi University of Science and Technology. And we are proud to introduce MagPub, a solution designed to automate neonatal respiratory care and save lives where resources are limited. Globally, approximately 2.3 million neonatal deaths happen each year, with over 80% of these deaths occurring in low-resource settings. Neonatal respiratory distress syndrome remains one of the leading causes of death in preterm infants, contributing to about 19% of the global mortality rate, therefore highlighting a major gap in access to effective respiratory support. Currently, there are several established interventions for managing neonatal respiratory distress, including high-end CPAP therapy, suffocant therapy, and antenatal corticosteroids. In more resource settings, these interventions have significantly improved survival outcomes, but their high cost and poor adaptability make their impact unequal. So they are life-saving, but not everywhere. The introduction of the Pumani CPAP significantly turned things around for low resource settings. So its effectiveness in improving access to respiratory support greatly reduced mortality from RDS. However, these systems still rely heavily on manual monitoring and adjustment, which introduces variability in oxygen delivery, sometimes increases workload, and it also limits the ability to respond quickly to changes in a patient's condition. To address these challenges, we developed MacPub, a low-cost automated neonatal CPAP system that integrates real-time physiological monitoring with intelligent control of oxygen delivery, thus improving consistency, responsiveness, and usability in low-resource settings. So the device itself is made of 2 components, that is the sensor module and the main unit. The sensor module is self-contained with its own power management, continuously sending real-time vitals wirelessly to the main unit. This allows the main unit, which houses the pump and the actuator, to be positioned safely at the bedside. So as such, by separating the sensor and the main unit, we have eliminated the need for bulky wires between the two. The core principle of our system lies in its closed-loop autonomy to reduce dependence on manual intervention. By receiving data from the sensor module, the control algorithm triggers a precise FiO2 adaptation via the actuator. So this sense and response mechanism ensures the infant receives regulated flow tailored to their physiological needs. Beyond respiratory support, the system is designed to function as a continuous vital monitoring platform, meaning even when a CPAP, even when CPAP support is no longer required, it remains active in displaying key parameters. And additionally, by utilizing selective pump activation, we try to optimize power consumption, making the device energy efficient. To guide the design of the MacBook, we defined key criteria based on the constraints of low-resource healthcare settings, like Malawi, which mostly included affordability, continuous monitoring, automated FiO2 control, and rapid response to physiological changes. Using these criteria, we compared MacBook with existing systems, which is essentially the Pumani CPAP. While the Pumani CPAP improves affordability and access, it relies on manual adjustment and intermittent monitoring. So in contrast, MacBook reduces reliance on operator input, lowers clinical workload, and improves consistency in oxygen delivery. Overall, MacBook is designed to address key limitations of existing systems through automation and intelligent control. To validate and evaluate the performance of the device, we conducted bench testing under controlled conditions where the system demonstrated successful flow control and wireless transmission, confirming the proof of concept and technical feasibility. However, sensor accuracy remains a limitation with errors exceeding 5%, and this is primarily due to limited filtering, calibration, and signal processing. So therefore, we've identified these as key areas of further development. Moving forward, we aim to improve sensor accuracy through enhanced calibration and signal processing techniques, with additional steps including system refinement by integrating safety features, onboard data storage, and multi-parameter sensing, and then progressing towards clinical validation and then regulatory approval. So these steps are essential for us to transition the device from a functional prototype to a deployable clinical solution. Our team brings together experience in biomedical engineering, clinical environments, and hands-on system development. This multidisciplinary background has enabled us to approach the problem from both technical and practical perspectives. Lastly, MacPrep represents a step toward more equitable neonatal care by combining affordability, automation, and intelligent monitoring. Thank you.
I might have missed this during your presentation. Can you tell us again exactly what monitoring parameter, like what is being monitored? Is it SpO2, heart rate? And how does that also interface with the existing monitoring systems? Do you have a new sort of patient interface for those sensors, or are you using what's already existing?
All right, so we are mostly monitoring SpO2 data. So the secondary parameter that we're monitoring is heart rate, but the main one was SpO2 data. And that data is being sent to the main unit where it's basically being interfaced or displayed, interfaced by a display. So the healthcare workers are able to see the data through a display on the main unit. Yeah, I don't know if that correctly answers the question or if there's more I need to add.
Yes, it answers the question.
Try to understand when you decide to use surfactant versus prenatal steroids versus CPAP, and in what part or which population are you really impacting? So is this a solution for all of those potential opportunities, or is it just to replace those that can benefit from CPAP?
So the solution is basically trying to help improve conditions on those that are accessing CPAP therapy as the main mode of treatment. So in most low resource settings, like for instance, in the case of Malawi, suffocant therapy and antenatal corticosteroids are not technically used. We use CPAPs. So our device is aimed to improve on the existing CPAP systems in the low resource settings. Yeah, I guess, yeah, that's mostly it. So it's not a solution for those other treatments, but it's more of an improvement on the one that is mostly used in the low resource settings. Yeah.
Yeah, while the U.S. has experienced a slow but steady decline, Peru has seen an overall increase in deaths per 100,000 women, as you can see on this graph from the IHME. And
Could you come a little bit closer to the mic?
Sure. Yes. So Peru's cervical cancer rates are far more turbulent over the years, and the mortality rates are increasing over time, whereas the U.S. has experienced a slow but steady decline. And this highlights the urgent need for a solution in terms of screening. And these inequities are especially concentrated in rural and mountainous areas, which is why Project Mesa is focused on affordable exam tables for use in mobile clinics. Project Mesa has developed a portable, low-cost gynecological exam table to address this issue. This lightweight yet sturdy table can accommodate prophylactic, diagnostic, and therapeutic gynecological procedures and is widely applicable for other medical uses as well. It can be manually transported, which is essential in mountainous rural Peru. And the unique aspects of our table allow us to greatly expand access to care in a sustainable, affordable manner, and we're allowed to meet patients where they're at. After our last needs assessment in Peru in 2024, we decided to increase the length and width of our seat and backrest to maximize patient comfort and maneuverability. Additionally, our previous iteration had cylindrical footrests, which were too narrow for patients and clinicians to get proper leverage during exams. In the 2025 prototype, we created curved foot supports that maintain the light weight of our table while improving ease of exam. The table has been both FDA and dynamically tested and is proven to hold up to 300 pounds of force. So shown here is an FDA test of the 2025 stirrup design and a CAD image of our entire table as well. So we're constantly looking for ways to get feedback from patients and clinicians. So we recently actually submitted our IRB application and plan to begin data collection through a survey once that is approved. Additionally, we hope to create add-ons for our table to support our community partners and their evolving needs. So in rural Peru, exams are often conducted on the floor or on a bed, and that compromises hygiene and patient safety. And we aim to address this issue while maintaining the comfort, encouraging patients to attend screenings regularly, and to facilitate the clinician's ability to provide the best care possible. So our table is currently being used in Peru, Nicaragua, Kenya, Uganda, and the United States, especially in USC Street Medicine for not only pap smears, but also prostate exams, colposcopies, and even leaps. It's a very sturdy table and can be reliably used over thousands of times per table. So these are some preventative and therapeutic procedures for cervical cancer, all of which are being safely performed using our table. The left shows screenings such as pap smears and well woman exams, and even prostate exams for men. Optimal patient positioning for everything shown here can be achieved using our table. The surgical procedures in particular, such as leaf colposcopy and conization, require unrestricted physician access to the cervix to avoid injuring other structures. Thus, we conclude that intentional design of the examination surface is essential for proper surgical visualization of the surface. Our design, if implemented on a sufficient scale, has the potential to save over 1,100 lives in Peru alone. With your support, we hope to prevent the disproportionate mortality of women in underserved communities all over the world. Thank you.
These makeshift surfaces that are currently being used, what's the problem apart from comfort? Is it access to the perineum? Is it the angle of the pelvis? Like, what exactly is the issue with what's being used currently?
So the issue is that like the positioning achieved with a gynecological table with stirrups and everything like that, you like again, yeah, the angle is not quite right, and it can like if you're trying to do things like leaps and conization, which is being done with our partner in Uganda, if you're trying to do something like that, you kind of need the positioning that can be achieved using a gynecological table, whereas like if you're using like a bed or the floor, it affects hygiene, of course, and it also affects the angle of the pelvis necessary to avoid injuring other structures in the area when attempting to do these surgical and visualization.
I heard you say that your system has been tested for up to 300 pounds. Could you talk a little bit more about your verification testing? I'm curious if that's coming from your computational models and or any benchtop testing.
Yeah, so we actually do outsource our dynamic testing for our table after we manufacture each one. So we get a full report after that, which just gives us all these numbers, which is what we pulled from. Yeah, so it's not just the computational models. Like we initially do that like before we manufacture whatever iteration we're working on at the moment, and then we outsource the dynamic testing to other companies, and they stress test tables, and then we get the data back from them.
I'm wondering, I suspect it was covered in the early part of the thing, but what are the materials and such that you've produced this out of?
So we use cold rolled steel. That's like a material that we found to be lightweight, affordable, and medical grade. And we use a powder coat to ensure that our table can withstand many uses. And we use a form of nylon for the cushion. So a measuring foam. We've also, in our newest table iteration, we look to use different materials for the seat cushions, and to test those, we've done different solubility and permeability tests to see which ones can be sanitized for the most amount of time.
Last question. You referenced rural and difficulty with accessibility, but do any of your prototypes exist in even hospitals where on one floor they don't have any access to gynecologic tables, where a patient has to be moved, transferred with the costs inherent to that, where those are available on a floor of a hospital that may have gynecologic tables of different quality on a set floor?
So our project is mainly focused on like mobile clinics and rural clinic centers. We haven't really explored the hospital avenue yet, because in hospitals they usually will have like a clinical grade gynecological table that's not usually portable, but we can definitely like look more into that after, if we're in later stages of our project, if we find that that is an avenue we can explore. But in right now we're currently just looking to decrease the mortality rate in rural areas.
Good day, everyone. My name is Joy Okoy, co-founder of the Health Guardian. Next slide. During my internship, a young, expectant mother was rushed to the emergency unit, but she lost her baby shortly after delivery. Weeks earlier, she had noticed an unusual fluid, but thought it was normal. It was the amniotic fluid, meant to protect her baby. This leakage led to infection due to preterm premature rupturing of the membrane, PPROM, that cost our baby's life. This is the sad reality of millions of Nigerians. Over 300,000 Nigerian women are affected every year. Nigeria ranks second globally in natal death. Sadly, up to 30% of this death can be prevented through early detection. And that is exactly why we built our solution, the AM detector. Our solution, the AM detector, is designed to be used by mothers to detect amniotic fluid leakage early, helping them to seek timely medical care. We designed our solution
Can you hear us?
to be very easy to use, non-invasive, and very portable. Yes, there are existing solutions like hospital tests. Looking at the screen, we can see that over 300,000 women are affected every year, making Nigeria rank second globally in natal death. Next slide. This is our solution, the amniotic fluid detector, a portable, reusable diagnostic device that can detect amniotic fluid leakage early, helping mothers to seek timely medical care. Next slide, please. This is a picture of us designing our solution at the University of Lagos Design Studio and Innovation Hub, where we built our first prototype. Next slide. Our innovative approach cuts across ensuring our solution, the AM detector, is accurate, non-invasive, and very easy to use. Please, next slide. How do you use the AM detector? Very, very easy. All you have to do is swab your fluid, place it in our swab chamber. Our device automatically runs tests and displays results. Amniotic fluid detected, seek medical care, or non-amniotic fluid. Next slide, please. Yes, there are existing solutions like the hospital test. It is very effective, but costly, good use, and designed to be used in hospital settings. Our solution, on the other hand, is reusable, designed to be cost-effective, and can be used by mothers at home with little or no medical expertise. It can also be used in clinical settings. Next slide, please. Projects that capturing just 5% of Nigeria's initial market would help us in generating over 25.6 billion naira, demonstrating strong upside even with a conservative market entry. Next slide. Our business model is simple, scalable, and sustainable. We sell directly to hospitals, NGOs, and consumers, generating revenue through our one-time device sale, recurring swap sales, and our app subscription services. Next slide, please. With a unit cost price of 35,000 naira and a selling price of 80,000 naira, we project over 54,000 naira profits per mother, helping us to directly break even by year 2 and growing profits thereafter. Next slide, please. For attraction, we have developed our first prototype, validated our research at the Lagos University Teaching Hospital, one of the biggest hospitals in Lagos, Nigeria, particularly in maternal and child health. We've also initiated patents, currently pursuing regulatory approvals, and have won global recognition as the Rise 360 Global People's Choice Award winner 2025. Next slide, please. And then the next few months, our next line of action is to develop mobile-friendly application, integrate artificial intelligence, and conduct further clinical trials. This is to boost user access, accuracy, and the effectiveness of our solution, the AM sector. As I conclude, please the next slide. Our team that is bringing this innovation to life cut across business, design, clinical experience, research, and technology, driven by seasoned mentors and united by a single mission. Please, the last slide. As I conclude, I invite everyone in this room to join us in saving newborns, one job at a time.
At the end, you said that future steps were to develop a mobile-friendly application. So I originally thought you were talking about something that a mother would use at home, but clearly that's something that's in the future. So other question I had was about the efficacy testing. You said you had 10 that had all had amniotic fluid. I'm wondering if you've moved on to a bigger sample where you could a little more precisely give us the positive and negative predictive value of this device. Thanks.
Thank you so much. So we are working with a range. For us to detect the amniotic fluid, we are using 3 different factors to determine if that fluid is amniotic or not. If it's positive for just one of those 3 checks that we are doing, the value is inconclusive. So for amniotic fluid, the range is between 7.1 to 7.4. And if we fall within that pH, it passes. Then it checks for conductivity. We are looking at the conductivity of about 1,600 to like 1,800. If it falls within that, it checks. Then we are looking at the timing, which is where the temperature sensor comes in. it takes amniotic fluid longer time to dry up. So we are looking at about 1 minute plus. So if it takes that time for that fluid to dry up, then it passes the 3 checks. Then you get amniotic fluid detected. Anything other than that, we tell you that the test is inconclusive and you have to try it again. And it is something the mother can definitely use at home. That is the main goal behind this innovation. That is the reason why we made our device non-invasive, and that is why we are making it something that is reusable. It is all the mother needs to do, no technical know-how, just take the swab, touch your vaginal discharge, touch it with that swab. The swab is like a cotton ball, and then you place it in the swab chamber of our device. That's all. The mother is not concerned about any technical know-how. The device does the scanning and then gives them the result. If it is amniotic fluid, that is the 3 checks, not 1, not 2. It has to pass the 3. If it is the 3, it tells them amniotic fluid detected, seek medical care immediately. And if it doesn't pass that, it tells them to retest. If it doesn't get an accurate result or a conclusive result within 2 tries, it tells them to go and seek medical care.
Okay, so to add to what my colleague has said, predictive, positive, and negative values so far based on our current test, we are looking at about 86% accuracy for the positive testing. But we also know that there are some conditions that may contradict our values, which is the presence of urine and other vaginal fluids. But we are working on improving on our prototype for now.
Yes, it can be used in the 3rd trimester. And she can use it at home. That is the main innovative approach of our solution. You can use it at home and it can also be used in the clinic. So yes, it can be used by the mother herself during the 3rd trimester.
Air pollution is ranked the highest cause of global disease. There are approximately 7 million deaths annually due to air pollution exposure, with 89% of these occurring in low and middle income countries. Disadvantaged communities tend to be placed near areas of land with higher pollution, and many of these areas lack air monitoring. This leads us to the main objective of our project. How can we create a device that gives accurate air quality level readings, is accessible for low income areas, and is simple to understand for all ages? Air quality is something that affects us all. Wearable technology allows individuals the power to take their health into their own hands, improving patient empowerment. As seen in the figure on the right, many countries lack accurate air quality monitoring systems, and even more do not provide fully accurate data to the public. Furthermore, current air quality monitoring devices on the market are costly, inaccessible, and bulky. The urgency for low-cost solutions is especially present in developing countries with populations that can benefit most from our device.
The greatest impact of our device focuses on increasing alert and awareness for those living in low and middle income countries, especially children, pregnant women, older adults, and those with respiratory problems. Being able to determine for themselves whether the air quality is safe can help them defend their own health and make decisions to protect themselves further. For example, a person wearing a monitor can identify different areas that have better air quality and find routes of travel to reduce exposure to that poor air quality. In 2019, ambient fine particulate matter PM2.5 reduced life expectancy by 1 year, household air pollution by 0.7 year, and ambient ozone by 0.07 years, nearly as much total as tobacco use. Improving air quality monitoring can lead to increased life expectancy as people understand and take the necessary precautions to protect themselves. Increased monitoring leads to a greater acknowledgement of the issue, which can then allow more solutions to be devised. The performance specifications for our device are referred to monitor the major indicators of poor air quality air quality. This includes carbon monoxide, particulate matter, and VOCs. The device will alert the user when air quality falls below acceptable levels, use a continuous light and discrete vibration system to ensure the inclusivity for as many users as possible. We also wanted the device to be secure and easy to wear.
This outlines the device diagram. Air will flow through the vents in the main housing to reach the sensor where it measures VOCs. It is connected to an Arduino where the data is processed and we can see TVOC readings. Based on the TVOC and calculated AQI readings, if a specific threshold is met for unsafe air quality, the device will vibrate. It also will shine a color corresponding to the air quality. As shown in the diagram, air quality levels progress from left to right, ranging from purple, which is very severe, to green, which is good air quality. The main housing can also be attached to either a wristband or a clip-on. The sensor we use for our device is the ENS 160 BGLM. It includes 4 sensors with metal oxide technology. The sensors can detect a variety of gases such as ethanol, toluene, hydrogen, and oxidizing gases by measuring the change in electrical resistance caused by the metal oxide is exposed to the air. In total, the sensor measures CO2, TVOC, humidity, and temperature, and from these values we can calculate AQI. The size of the sensor is small, at 3 by 3 by 0.9 millimeters. In order to keep costs low, the sensor is inexpensive without sacrificing accuracy.
For the main housing design, we needed to build something small enough so it fit comfortably, but large enough to contain the necessary components. It also needs connections for different attachments, as well as having covered vents allowing for airflow while minimizing debris intake. For material choice, we decided on PETG for 3D printing, as it is thermal, chemical, and water resistant, while remaining very durable. The cons of the material are that it's slightly more expensive and difficult to print with. For testing purposes, we did use PLA as it was accessible and easy to use, but from our understanding, PETG should print similarly. We wanted our device to be comfortable and adjustable for the user. The wristband was made of TPU, a rubber-like material, which is flexible and durable. It has multiple buttons and buckles to fit the size of the user's wrists. The clip-on attachment was made of PLA, as we were less worried about water resistance, and it could be hooked to clothes, bags, or other items. These objects enhance usability, as the device can be placed in a convenient position for the user, which aims to increase the likelihood that an individual will use our device.
In order to notify the user of a change in air cooling level, we incorporated 2 alert systems using a vibrating disc and light-emitting diodes. The LED system will display a specific color in the sequence seen on the slide corresponding to the air quality index, with green representing the most safe and purple representing the most dangerous air. To ensure our device works for as wide of a population as possible, the air quality level detected can be understood from just the vibration system, as if we'll have varying vibrational patterns corresponding to each AQL level. We tested our device against an already existing air quality monitor called the Air AE Steward Multifunctional AQM. We calibrated this air quality monitor to be able to standardize each experiment per condition tested. This allowed us to see the accuracy of our device reading. We carried the testing of our device outdoor with conditions including 70% ethanol solution, burning a candle, and mixing baking soda and vinegar. From the graphs to the right, we see that our device is much more sensitive to VOCs, but the relative output between the conditions is comparable between the devices.
A water-resistant housing is important to protect the electrical components and the sensor of our device. The vents on the housing are necessary to ensure proper airflow to the sensor, but also susceptible to water entry. Polytetrafluoroethylene membranes provide water repellency while maintaining gas permeability and can be added over the vents in the future. Comfort and choice remains a key factor in our design, and thus adaptations to the wristband can be made by creating a fabric strap option, as well as potentially testing silicone molding. By adding another type of sensor to the device, we will be able to measure particulate matter and therefore more accurately measure the safety of the air around the device. Thank you.
Do you have any data in real life atmospheric conditions?
So for right now, we haven't done any testing in super poor air quality regions. We weren't able to get around to it. For us down here in San Diego, we're very fortunate to have good air quality. So the readings were working well. However, we did test in our makerspace, as we got it working to begin with, and there were a lot of toxic compounds in the air, and as you can imagine from all the soldering and 3D printing going along in one room that wasn't very well ventilated. So that's kind of the best we have as of right now.
Hi, thank you for the presentation. That was really great. I have a quick question. I'm from New Delhi, which is famously the most polluted city in the world right now. And I wanted to ask more specifically about your use cases, because we already know we're living in a really polluted city, and so I think that's not our main concern. I wanted to know where your device fits into the paradigm of what do you do when you know the city's already polluted, because I think in that case, I'm trying to see where the use case would fall.
I think relativity is really important. Obviously, air pollution can change over time and worsen or get better at different points of the day or even throughout the week. So this air quality monitor can be used to even see how dangerous the air is at a specific point in time and whether you should not be outside, because there are certain air pollution levels that maybe is safe, maybe not ideal, but it's still safe for people to be outside in. And additionally, it can be used to see where better air polluted areas are. And then when you're traveling, you can go through those routes instead, that kind of thing.
I want you to take a moment and look at this picture on the right side of the screen. This is the dream of every mother, to be able to hold a child and know that the baby is safe. But unfortunately, from where I come from, or Nigeria, that isn't the reality of many of them. This is a map of Owo, and here, that's my university, and that's the Federal Medical Center, very close to my university. It takes a few minutes to drive. But in cases of emergencies, mothers that are far away, like Imre, Ile, Ipele, they have to drive far and long distances. And it's just emergencies that make them go to the Federal Medical Center. And as we know, neonatal jaundice doesn't pose itself as an emergency at first, which makes this problem a problem of early detection. Speaking with those on the front lines, this is Dr. Adefemi Barnabas that we spoke with in the Federal Medical Center, Owo, and he told us something consistent that continually happened. Mothers, unfortunately, can't detect jaundice early. Why? Not because they don't care, but because they have no idea about it. And by the time they realize jaundice could lead to brain damage, which is kernicterus, and then death. This is actually a bigger issue globally because in Africa, we have over 85,000 deaths due to neonatal jaundice. Nigeria has the largest share, 15.3%, average of 13,000 per year. That is a big problem. And then we asked ourselves, what exactly was the problem? What exactly was the problem? And we realized that the available methods for detecting neonatal jaundice are not built for low-resource environments. Firstly, the bilirubinometer costs over $500, not affordable for community clinics, like I showed you in the map. Blood test is invasive, it requires medical accuracy. People don't really want to go walk in the rural communities. And then visual check by mothers. That can't be trusted because we have several variations of jaundice. We have pathological, we have physiological jaundice. So we can't trust that. Not to compare 44% of Nigerians that live in rural settings. We have over 200 million Nigerians, so that's almost 100 million living in the rural settings. Then we widen the scope of our question. What if we could have a method for detecting this which was non-invasive, accessible, and inexpensive? Which made us come up with a design rationale that's very simple. Make it less costlier than all alternatives, reduce the screening time, no extensive training required, and that gave birth to what we know as LumiCare. LumiCare is very simple. It's an AI-powered platform that uses machine learning to detect jaundice, all with the use of a smartphone. How does it work? Very simple. The mother takes a picture of the baby's eye, the sclera, it goes through our machine learning model, and then she gets a bilirubin risk prediction. If there's any sign of any risk, it immediately recommends you to the nearest pediatrician or medical facility around you. This is a demo that shows how it works. Just like you can see here, you take a picture of the baby's eye, a close shot, and then you upload the image, and then the mother gets a bilirubin risk prediction. And then can be recommended to see a doctor if there's any risk detected. LumiCare is more than just a screening platform. It has accessibility involved in it. Nigeria has over 250 ethnic groups, and the major languages that are spoken in Nigeria are Yoruba, Hausa, and Igbo. And we integrated that into LumiCare. We have the 4 languages that are integrated into our app. So if a mother can't speak English or language is a barrier, she has access to actually change languages. And then there's also a chatbot that could help in terms of any question that she might need answers to. So far, our model achieves 92% accuracy. The 4 languages supported, like I mentioned, runs on any smartphone. It doesn't require a high-end device because our target community is the low resource settings. It's skin tone universal, but LumiCare has its own fear of limitations. I will admit that. We have a small data set, which is limited diversity, and sclera sometimes could be hard to capture in newborns, which is why we're currently working on a skin model, which I presented last year in Denver, Colorado, in Opticals conference. We're working on that so that we could have another input feature, apart from the sclera, that could detect or give a risk for jaundice. So, LumiCare has been able to achieve a lot of success, one of which is what I mentioned earlier, but we plan to expand our data set, get more data, have a clinical pilot with several hospitals like the Federal Medical Center, which is very close to where my university is, an app launch, which is the multimodal type that I mentioned, not just the sclera, but having the skin feature as an input, and then scale beyond just our to other places in Africa. With LumiCare, we believe that a baby's life should not be determined by where he or she is born. And with LumiCare, we know that we can make early detection accessible and give the mother a smile on her face at last. Thank you so much.
How many data points would you say you use for training the model at present?
It's on Mendeley. I'm sure we know what Mendeley is, like a popular. We worked with. So I found two researchers that had worked on it. Her name was Fatemi, and the other one was Professor Ali in University of Australia, and they had worked on several data sets. So I got the data. It was over 200 images. That was for the skin. That was for the skin model, and for the issue with this sclera model is that we've been unable to get enough data. So that this is a proof of concept that shows that, oh, we can achieve this. So if we get more data, we can actually work more and increase the accuracy.
I have a quick question. Yeah. Thank you for your presentation.
Thank you.
What's the prevalence of smartphones in the rural area you're targeting, and also literacy, even in the native language?
Okay, so the thing about Nigeria is there's a smartphone everywhere, but the medical center is far away. I don't know if I could go back to the slide. This looks small, but it's long kilometers away. So everybody has a smartphone, and then even as a low-end device with 5 MP, that could work. So the why we use the smartphone is because, there's even if the mother doesn't have a smartphone, there's someone outside that you could, please could you lend me your smartphone, and then I use it to test or check the baby.
Hi, we're Gateway, and we're excited to share our project with you. Parkinson's disease is the fastest growing neurological disorder globally, and there's a large disparity in access to care in developing countries. Fewer specialists in low-income countries mean that patients with limited mobility often have to travel nearly 50 kilometers to reach their nearest physician. Instead of bringing a patient into a clinic, we want to enable patient monitoring in their own homes. One of the main symptoms of Parkinson's disease is gait impairment. Patients often experience alternating on periods where medication improves movement and off periods where symptoms return, including an increased risk of falls and aspirations. Because motor symptoms fluctuate from hour to hour, a single measurement in a clinic fails to capture the variability a patient experiences in daily life. Additionally, these patterns of gait fluctuations can serve as indicators for long-term disease progression. Current solutions are either too expensive, too limited, or not suitable for a patient's lifestyle. Existing systems can cost nearly $5,000, while we designed Gateway to be less than $100, making our design more accessible to patients in low-income countries.
We focus our design on wearability and easy integration into normal activities, resulting in a network of 1 wrist bracelet and 2 socks. The casing box, which houses our electronics, can conveniently snap into anchors in either configuration. The device is low profile, allowing it to seamlessly be integrated with minimal visibility and user discomfort. We designed a PCB which combines an inertial measurement unit and an ESP32 microcontroller, allowing us to track acceleration and motion. From there, the data is transmitted via Bluetooth to a laptop, where our software processes gait patterns into a gait score, which is then visualized on our mobile app.
Let's move on to talk about our results. Beginning with data obtained from the ankle sensors, we implemented a rules-based algorithm to detect key gait events like toe-off, mid-swing, and heel strike. Stride duration was calculated as the time between one toe-off to the next. For data obtained from the wrist, we implemented a Fourier transform to view the raw periodic signal in the frequency domain. This allowed us to extract a dominant walking frequency, which we then used to derive metrics like arm swing, cadence, and stride duration. We validated our parameters with known control trials and compared the stride duration obtained from the wrist to stride duration obtained from the ankles. We noticed that these closely matched each other, as well as the expected value of 2 seconds, shown by the dotted red line in the box plot. We also conducted a trial with a fixed pace and a decreasing pace, and noticed an expected increase in stride duration over time. Additionally, we simulated normal and abnormal gait, and noticed that in the normal trials, represented by the blue box plot, we had a stride duration of roughly 1.05 seconds, versus in the abnormal, represented by the red box plot, we had an increased stride duration and greater interstride variability. Additionally, the abnormal trials had a decreased arm swing amplitude, which is consistent with how we conducted the trial. Furthermore, the abnormal trial had a higher double support time and percentage, which is defined as the time both feet are on the ground. Higher double support time corresponds to more gait instability and shuffling, which is characteristic of Parkinson patients.
Now, let's move on to tremor detection. At this stage, we do not have access to clinical data, but we are able to detect deviations from normal healthy walking as shown. 0 tremors were detected in the healthy walking trial, while 8 episodes were detected in the abnormal trial. Here is a diagram showing our data processing pipeline to better visualize our workflow. We first pre-process raw gait signals to extract key lower and upper limb parameters. Then we use machine learning models to predict probability of Parkinson's disease. Finally, we obtain the gait score, which is a single interpretable number ranging from 0 to 100. To determine whether our own device would be able to produce a meaningful gait score, we passed data from our healthy and abnormal walking trials through our model. The model was able to successfully distinguish between Parkinsonian gait and healthy gait and assign the Parkinsonian gait a correspondingly lower gait score.
For ease of access, we developed an app that allows patients and clinicians to view their current gait score, trends over time, and future predictions. Based on feedback from our clinical partners, we learned that 1, patients do not always adhere to their prescribed medication schedule, so clinicians lack information on true medication timing. And 2, the goal of objective gait monitoring is ultimately to improve the subjective experience of patients. Hence, our app will also enable patients to log their medication intake and their subjective assessment of gait quality. Going forward, we're hoping to explore flexible PCBs for improved wearability and utilize vision-based tracking for further system validation. In the longer term, we hope to work with patients to conduct trials, which allow us to monitor medication-induced changes in gait performance and provide suitable recommendations. Gateway reduces the cost of wearable gait sensors and increases access to continuous monitoring of Parkinson's disease. By mitigating motor symptoms and shortening these off periods, we can dramatically decrease the risk of falls and aspirations, keeping patients safer and healthier. Gateway isn't just a device, it's the gateway to greater independence and mobility for all patients around the world. Here are our acknowledgements. Thank you, and we'll be happy to take any questions now.
You said there were some trials that were normal and some abnormal. Were the abnormal trials in known Parkinson's patients?
No, we were unable to test on actual Parkinson patients due to clinical limitations. So we tested it on ourselves, and we were comparing our baseline as normal to simulated abnormal. So we were intentionally walking with more of a shuffle and a slower pace. We conducted 5 trials overall, so 3 of them were more validation. Those were the known parameters that I was referring to. And the way we did that was we taped the ground. We had a ruler. So we measured the distance between them, and we were also walking with a metronome. So that's how we were able to get metrics like stride duration and distance. And then for abnormal and normal, we kind of were just using ourselves as a baseline, if that answered your question. We have a slide on here.
Question about your app that's actually really conveniently the slide that's up right now. How are you, as I'm looking at this app, what considerations have you taken for the ability of someone with Parkinson's to be able to use the app, accessibility issues like that? Could you talk to that?
Yes, that's a good question. We made all of the buttons and everything very accessible and straightforward. We have the subjective kind of questionnaire, but this is not required. Really, the main part is the app being able to show the gait score, so that doesn't require any input into the app. But when a patient is feeling their best and when they've taken their medication, they're able to log that medication intake and backtrack it as well. So it doesn't have to be like right when they are inputting that data point. So it can really be based off of when the patient is feeling their best throughout the day.
And I'm unsure of the source of the machine learning model. So where do you get the data from? Is that from the simulations?
Yeah, well, we trained our machine learning model on an open source Parkinson's data set. So even though we weren't able to conduct our own experiments on Parkinson's patients, that data did come from like a verified source. So we just extracted the same parameters that we're using with our model, and we compared those baselines, and we were able to apply it to our own data.
Hi, everyone. We are the Virginia Tech Reusable Skin Stapler team, and we are so grateful for the opportunity to present our work here today. We'd like to start by asking you to consider this scenario. Imagine sitting in a packed emergency room in Malawi with no guarantee that the surgeon will have time to treat you that day. For millions around the world, this is a lived reality driven by limited access to essential surgical care. According to the Lancet Commission on Global Surgery, this lack of access contributed to an estimated 16.9 million preventable deaths in 2010. For our team, this global statistic is personal. As our clinical advisor, who first identified this need, shared with us, there is more need for operative care than there is time in a day. These deaths can be attributed to a lack of surgical infrastructure and tools in an already overburdened healthcare system. For wound closure, clinicians must utilize either sutures or staplers. Sutures are the primary method in low and middle income countries. However, they are time-intensive for larger wounds and often prolong operative time. Staplers are preferred for their speed and reliability, but they are difficult to sustain long-term as they are single-use and extremely costly to acquire internationally. These challenges highlight a clear need for a surgical solution that is affordable, sustainable, and accessible in low-resource environments.
Which brings us to our open-source reusable skin stapler, an ongoing project that our team has been developing over the past 8 months. Our design considers the entire ecosystem, from staple fabrication with our jig all the way to staple deployment with our device, while maintaining the speed and functionality of a traditional skin stapler. Every step of the process is designed to be independent of any global supply chains, which has led us to focus in on 3 main areas. Clinically, the device must safely and effectively close wounds. Mechanically, it must withstand multiple sterilization cycles. And to ensure accessibility, all parts are designed for local fabrication and long-term reuse. With components such as a reloadable cartridge that locks into place, simple internal mechanisms that allow for repair if damaged, and a fully sterilizable device. This design supports safer use across multiple procedures while reducing cost, waste, and dependence on any single-use medical supplies. Here is our stapler prototype. The outer components, such as the shell, handle, and cartridge, are made from a polycarbonate carbon fiber blend. The internal components, such as the pusher and the anvil, are cut 2D from stainless steel for mechanical integrity and fabrication simplicity. Equally important, here's our staple forming jig. Our staple forming jig is made from PETG and PLA. It allows for the fabrication of 25 uniform staples per cycle, ensuring that the device and its consumables can be produced and maintained within the same ecosystem. After we developed our prototypes, we then moved on to verification testing, and we are super excited to share our results thus far.
We began with usability testing, where users were given a completed instruction manual to guide them through several workflow assessments. These included using the jig to form staples, loading and unloading the cartridge, and assembling the entire stapler. From this, we were able to verify the real-world functionality of our device and ecosystem and ensured smooth adoption to existing healthcare workflows. Next, we tested sterilization at a temperature of 120 degrees Celsius using a simulated autoclave. Our device has maintained its integrity and functionality after multiple sterilization cycles. Finally, we have tested the mechanical durability of our device using drop tests and force testing. We have analyzed the amount of force required to deform a staple for both a commercially available stapler, shown in orange, and our reusable skin stapler, shown in blue, and we have found that our device is comparable to those currently on the market. We have two major successes at this time. First, our cartridge is reloadable, reusable, and securely locks into place. Even more exciting, we're able to deform a staple in open air, indicating that our mechanism is viable. However, we are currently facing limitations, translating the success into implanting staples into tissue models, and our next steps are working towards this.
We are optimistic about the path forward for our device. Throughout this project, we have been incredibly fortunate to have advisors representing multiple sectors in Malawi, including healthcare, academia, and industry. We've worked directly with trauma surgeons who have practiced in Malawi, prototyping partners in biomedical engineering at the Malawi University of Science and Technology, and potential manufacturing partners in country. With the support of these partnerships, our next steps start with conducting usability testing. This will be followed with the exploration of local fabrication and manufacturing capabilities, clinical validation studies in the US and Malawi, and finally CE marking to enable international clinical use. This supports our long-term goal to scale up production through local partnerships, whether that is in Malawi or other areas facing the same barriers to accessible surgical equipment. While this started as a project for us, it has grown into a responsibility. Conversations with our in-country partners have made it abundantly clear that there's a tangible human cost associated with this fundamental lack of accessibility. In response, we're developing a skin stapler that is affordable, sustainable, and locally manufacturable, working towards an improved reality where every patient can get the care they need and deserve. Thank you.
You mentioned that your design is open source. Is it available on the web right now?
Yes, we have all of our CAD files as well as a drafted instruction manual uploaded to an online repository on GitHub, and that is publicly available.
At the beginning, you talked about saving time. Can you talk a little bit about how much an OR equipped with a stapler versus one that's reliant upon stitching? What's the difference in time there over the course of a day?
So from literature, we've seen that suturing is significantly prolongs the operative time for wound closure as opposed to stapling. I believe the estimate is between 2 to 14 minutes for larger wounds. In our use case, where our advisor identified this need, staplers are used for larger wounds such as skin grafts, require significantly longer time, and reducing that time even by 15 minutes can increase the amount of patients that can be seen that day, and even one more patient can get seen and treated. Yes.
Does that analysis also include the time and follow-up with regard to staple removal? And was there, I know it's expensive, but was there any comparison or consideration with regard to the expensive glues that can also be utilized as a substitute for suture and for staple that don't require removal?
When talking with our clinical advisors who practice in Malawi, they told us that staple removal is something that can be done in home. Patients, they have a mobile clinic that can go to patients to do the staple removal. So patients still have to come into the clinics to get the staples implanted to close their wounds. But once they leave, the follow-up is very simple and much easier to sustain versus a suture. And then looking at glues, that was something that we additionally identified initially. However, they face the same barriers to implementation that staplers and sutures face, such as cost and supply chain as well.
Staples will be very important for big wounds like abdominal incision where you need a strong force. A glue cannot do that. A glue is good for a little cut on the face, so the uses are slightly different. And then absorbable sutures, again, tend to be weak. So I think for major surgeries where you need a lot of wound strength, the staples are better.
I'm sorry, I don't hear very well. Can you just verify that it is autoclavable, and does it require a different autoclaving regime than normal surgical instruments?
Yes, so we tested the sterilization of our device as a disassembled prototype. So we disassembled the device and individually sterilized the components and then reassembled. And we did that through a simulated autoclave, and that replicated the conditions that are required for successful steam sterilization. So it can be sterilized at the standard conditions.
Somewhere in the world right now, a premature baby has 2 weeks left before their curable eye disease turns into permanent blindness. This bottleneck is not an issue of lack of robust treatment, but rather a lack of a reliable early detection system. We are Team Retinex, and we're aiming to address exactly this issue. This eye condition, called retinopathy of prematurity, occurs when premature babies are overexposed to oxygen, resulting in abnormal retinal growth, and then later, if left untreated, retinal detachment and permanent vision loss. ROP occurs over 5 stages. This 2-week treatment window mentioned earlier occurs during stage 3, in which laser treatment can reverse this condition. However, starting at stage 4, permanent vision loss comes into question, and this treatment is no longer as feasible. This leads us to some of our gold standard solutions that are currently not working. So even though we know the treatment, why and how are babies still losing their sight? These gold standard treatments are expensive, they require specialists to operate, and they are bulky and hard to transport. For example, the RetCam Envision found at its cheapest at $14,000 and used. This means that retinal screening is simply inaccessible in under-resourced areas like our client country, Kenya. And finally, this brings us to Team Iris. Team Iris is a team that worked on this project before us and built a working prototype of the device, as well as an AI detection model. While this was a great start, there are definitely areas for improvement, including the casing of the device, and most importantly, image capture, as the resolution and the field of view are not currently capable of detecting ROP. With all these considerations in mind, we started building.
Thank you. So we focused on 5 main design criteria. First up, we have precision. We need a high enough field of view and resolution to be able to capture clinically useful retinal images. Next, we are aiming to keep our device under $500 for low resource areas. Third, we aim for the device to be compact enough so it can be transported by one person. Next, usability. Nurses with limited training should be able to operate the device. And lastly, safety. We are aiming to be under international safety regulations for light exposure. With all of this in mind, we developed our solution, a handheld retinal screening device with off-the-shelf parts for under $150 currently. Now, Alicia is gonna give us a quick demonstration of a typical workflow. So the baby is lying on the table, as you can see. The nurse picks up the device, aligns it against the eye, and checks the image on the user interface right here. Once the image is focused, then the nurse captures the image using a button. Now, what's happening underneath the device? First up, we illuminate the eye using high output LED, which gives us sufficient light to reach the back of the eye. To ensure safety, we basically separate the hazardous heat from the infant's eye using fiber optic cables, which route the light from the back of the device to the tip of the device. Next, the reflected light is magnified using a standard 28D ophthalmic lens, which gives us around a 70-degree field of view, which is enough to see the peripheral retina where early cases of ROP develop. The next image is captured using a 64-megapixel ArduCam autofocus camera, which gives us sufficient resolution for capturing fine vascular details. And lastly, everything is processed on the onboard Raspberry Pi, which handles things such as focus and brightness, as well as on-device image processing. And after that, everything is handled by our RetNext app, which handles storage and analysis.
The RetNext app, created using Python and using the Qt framework, is designed to make it easier for the nurses to interact with the device. It contains various features such as multi-language support, including English and Swahili for our Kenyan audience, an integrated patient data management system, a live camera feed from the device, and an image gallery to review previous captures for later review. Currently, from resolution testing using a USAF 1951 test target, our device can sufficiently resolve fine vessels on the eye for screening. The device can also achieve a 60 to 80 degree field of view, which is sufficient to detect more severe cases of ROP and plus disease. However, since higher quality lenses aren't used, optical clarity can be severely improved for better light transmission and reducing internal reflections. The field of view is also not enough for the 120 degrees required to detect the retinal periphery for earlier stages of ROP. Finally, babies are difficult to keep still, leading to potential motion blur during capture of the image. This leads us to our future plans. To reduce costs overall, we aim to work with existing industry collaborators to provide components at a cheaper cost through mass manufacturing. We also want to develop an image stitching pipeline to achieve the 120 FOV required for full view for screening ROP. We'll also improve our fiber optic cable to provide a more uniform distribution of light and illuminate the eye. And finally, we plan to go through the RB testing process to undergo clinical testing.
Again, we are Team RetNext, and we're working to build a future in which ROP screening can be more accessible for all.
Thank you. It's nice to see you improving on a previous design. It seems, though, that if you've got an image of the retina, you might be able to do other ophthalmological tests if your software allowed a module to be added for that purpose. Have you considered that?
We aim to detect ROP since that was what our client gave to us, but currently if it can be seen within the zone 1 of the eye, that 60 to 80 degree range, the device can detect any of these retinal diseases that might be found typically. But since our device is aiming for this more harder to detect disease that has to see the periphery of the retina, that's what we're aiming for.
We're essentially trying to do a little bit more than what the problem asks so that in future iterations in which we might be screening for other retinal conditions, because we're screening everything from the periphery to the center, it would be more possible to do that.
Do you have any pictures with the current device to show us?
Yes.
Yeah, this is a picture taken by our device. This is actually a test pocket retina, which actually has few other pathologies in the picture itself. So, for example, those black dots that you can see are actually other pathologies that you can detect through the retinal screening.
Is part of the bottleneck the assessment of the retina? Like, do you need a trained pediatric ophthalmologist to give you guidance as to whether or not this is retinopathy or not?
So the bottleneck stems more from just being able to detect this disease in the first place. Retinal screening as a whole is not very accessible in under-resourced countries just because these gold standard devices are so expensive, hard to transport, like in Nairobi where they have to be transported amongst 5 different hospitals. So quite literally the bottleneck is just the screening.
I'm Barrett.
And I'm Devin.
And this is Maternal Screen, a device for malaria and trichomoniasis diagnosis. Despite major advancements in diagnostics, many infections in pregnancy remain undetected in low-resource settings. For example, malaria remains a major global health burden, with approximately 263 million cases and 600,000 deaths occurring annually. Plasmodium falciparum, or PF, is the deadliest malaria parasite, and uniquely, it's it can sequester in the placenta during pregnancy, evading detection in peripheral blood. As a result, placental malaria is a major contributor to infant and maternal mortality. When placental malaria occurs in co-infection with Trichomonas vaginalis, or TB, these outcomes are further worsened, leading to complications including preterm delivery and low birth weight. Importantly, these conditions are treatable when we can detect them. Current diagnostics rely on blood samples, which are invasive and make it difficult to detect placental malaria. While highly sensitive methods like PCR and microscopy exist, PCR is extremely expensive and microscopy requires highly trained personnel for accurate diagnosis. Conversely, rapid diagnostic tests are readily accessible and inexpensive, but they are not sufficiently sensitive to detect placental malaria. No currently available diagnostics are both sensitive and accessible, making them unsuitable for use in pregnant populations.
To address the limitations in existing diagnostics, we defined 3 design requirements for our system. First, we wanted to eliminate the need for cold chain storage. Our diagnostic assay currently relies on temperature-sensitive reagents, which limits its use at the point of care. To address this, we lyophilized or freeze-dried the reagents, which allows them to be stored at room temperature while maintaining stability. Additionally, we wanted to enable rapid DNA amplification without relying on expensive laboratory equipment. To achieve this, we designed a feedback-controlled heating circuit using low-cost hardware to enable quick amplification and support the goal of same-visit diagnosis and treatment. Finally, we wanted to prioritize accessible design that is approachable for users without extensive training. We aimed to minimize user steps and provide results that are easy to interpret, which we did through the use of lateral flow strips. These design requirements inform the development of our final device, maternal screen, which uses a non-invasive urine sample and combines lyophilized reagents, a low-cost heating circuit, and lateral flow readout to enable detection of PF and TV in pregnant populations. The diagnostic assay at the core of our system was developed in our lab, and the goal of this work was to translate this assay into a deployable point-of-care format. Here we show the workflow for using maternal screen in a point-of-care setting. First, the clinician rehydrates the lyophilized reagents using a patient urine sample. This mixture is then transferred to a reaction well plate, and then this reaction plate is inserted into the device, and a thermistor is placed in a separate well with buffer to enable temperature monitoring during the reaction. Finally, the amplified product is applied to a lateral flow strip for easy visual interpretation of results. And most importantly, this entire workflow can be completed in under an hour, which supports the goal of same-visit diagnosis and treatment.
We successfully lyophilized PF and TV reagents and demonstrated amplification and detection in human urine, which we saw read out on these lateral flow strips you can see on the screen with our negative controls negative and positive TV and PF samples. We also demonstrated amplification of PF DNA in our integrated device, again confirming readout with lateral flow strips. And finally, we demonstrated lyophilized reagent stability for up to 2 weeks at room temperature and a PF limit of detection down to 0.06 copies per microliter, which is clinically relevant for placental malaria.
While this work establishes a strong foundation, there are still a few limitations that can inform possible future directions. As we mentioned, our stability testing of the lyophilized reagents was limited to a 2-week period, so future testing should extend this time period to determine the true shelf stability time of the reagents. Additionally, our system currently relies on a benchtop power supply, and transitioning to battery power would make the device even better suited to the point of care. Finally, all of our experimentation was limited to a laboratory setting, and so future work should look at using real patient urine samples and testing the device in clinics at the point of care.
For our path to clinical validation, we aim to deploy maternal screen in maternal health clinics in Kenya through our partnership with Dr. Jesse Gitaka. Our lyophilized reagents, simple workflow, and visual readout make our device well suited for point of care use, and we'll work to validate this on clinical samples in real world settings. Finally, maternal screen costs $54 compared to over $4,000 for PCR equipment and $11 per test for consumables, achieving our goal of remaining accessible in resource limited settings. In conclusion, maternal screen enables same visit diagnosis and treatment, reducing maternal and neonatal complications in low resource settings. And most importantly, it brings accessible PF and TV diagnostics to the point of care where they're needed most. Thank you.
Thank you for the great presentation. Could you go into a little bit more depth on like the workflow of once you've done the amplification step and then you're putting it into the, how do you go from amplification to next steps?
Sure. Do you want? Okay. So once you take the amplicons in the polypropylene well plate out of the device, you unseal them and you take approximately 6 microliters of sample out of the well and you mix it with an extraction buffer. Then you apply that mixture to the lateral flow strip. It takes about 15 minutes to read out and it applies a control line and a test line, which if we go back, you can see here, the control line is marked by C at the top, and then we have our primers tagged with 2 different tags, DIG and FAM, which are just antibody tagging. TV is tagged with FAM, so it shows up on test line 2, and then PF is tagged with DIG, so it shows up on test line 1. So once you apply it, again, after 15 minutes, you can read visually. If there's a test line, it's positive. It might remind you guys of like an at-home COVID test you might have done when you felt symptoms, and then therefore it's really easy for personnel to detect without having to be highly trained on what a readout might look like, if that answers your question.
I wanted to ask, it looks like your trials are in a place with a very high prevalence of malaria. You may not have thought about this yet, but in terms of like positive and negative error, how would you expect that to change if this system was deployed in areas of lower prevalence?
Yes. So the limit of detection data that we presented is in buffer, and we expect the limit of detection to rise in human urine from interference of salts and other proteins and things like that in human urine. Because of that, we would expect there to be a higher limit of detection, which might take us up to closer to past like the clinically relevant limit of detection. However, our published data that I mentioned did demonstrate a limit of detection in human urine down to 0.1 copies per microliter, which is still clinically relevant for placental malaria. And so we believe that it does still have the potential to positively detect even in, like I said, human urine in low resource settings. Another challenge is that our limit of detection data we ran in a thermal cycler, not in our device. And so there's a possibility that the thermal cycler maintains more exact thermal conditions, and then therefore our device would have a lower limit of detection. But again, that's data that we don't have yet and would hopefully be able to validate through our collaboration with Dr. Jesse Kataka, like I mentioned.
Hello everyone, we are Miss Cersei, our multispectral and infrared cellulitis expression. Cellulitis is a very common bacterial infection, skin infection, where bacteria enters the skin through a cut or wound and leads to an infection. Hospitalization can occur within 7 to 10 days of disease onset and lead to death if left untreated. In 2019, there were 43 million cases of cellulitis reported globally, and this led to over 18,000 deaths. Dermatologists are considered the gold standard for cellulitis care. However, there's only an average of about less than 3 per 100,000 individuals, with this number being even lower in low resource settings as well as rural areas. Therefore, it is much more likely that a patient sees a non-specialist. If a patient sees a dermatologist, they will most likely receive the correct diagnosis. And while this is possible if they see a non-specialist, it is much more common for them to be placed under continued observation or misdiagnosed. Dermatologists cite a lack of post-diagnosis monitoring as a primary concern in the cellulitis care pathway. And there's an estimated 26.5% misdiagnosis rate of cellulitis in emergency department cases within the US. Furthermore, this disease has variable presentation across different skin tones, making it very difficult to diagnose and treat. If a patient is given the correct antibiotics, they will recover. However, if they receive the incorrect antibiotics, are sent home to self-monitor for an extended period of time, or given the incorrect treatment, they will likely end up back in the hospital. Therefore, we identify an unmet need in the monitoring phase of the cellulitis treatment pathway. This unmet need requires a device that is low cost, portable, easy to operate, and has a high biomarker detection accuracy. Current solutions on the market include ISA, an AI-based mobile app, a thermal imaging and blood test prediction model, and a handheld magnifying device. However, none of these solutions meet all these criteria. This is where we introduced Miss Cersei.
For the monitoring of cellulitis, we focus on two main biomarkers. First, we focus on two main biomarkers. First, we measure temperature asymmetries to identify areas of inflammation. And second, we measure chromophore concentrations to identify regions of interest. Okay. And second, we measure chromophore concentrations to identify these chromophore values that we're interested in. Here's how we integrate this into our design. Our design has two main sensors, a multispectral sensor and a thermal infrared sensor. The multispectral sensor captures reflected light at specific wavelengths, allowing us to estimate these chromophore concentrations of oxygenated and deoxygenated hemoglobin. And this is essential because cellulitis infection affects local blood flow and oxygenation, which is in turn reflected by the changes in the levels of these two chromophores. For our thermal imaging, we do this to identify our regions of interest, and this is important as cellulitis infection is characterized by an increase in about 3.7 degrees Celsius compared to healthy, unaffected regions. So we have an imaging algorithm that combines these two pieces of information and produces an output which includes the lesion area and the heat map. So here is the user workflow of our device. Day one is going to be at the clinic, and the primary user is going to be the physician. And they'll do the initial setup for the device, and there at the clinic, they will take wide-field thermal imaging, and this is, to identify those inflamed regions, where we're in step 3, we'll go closer and we'll identify, we'll get these chromophore values that we're interested in, so the device is going to be held up against that inflamed region. And after that, the patient will take the device home with them, and they'll repeat steps 2 to 3 every 48 hours as literature suggests. And this is the user workflow. And for our thermal analysis, we wanted to ensure that we're getting spatial temperature detection, and we were also identifying these regions of interest. So we set up a simple experiment using heat packs as a simulation for infection. So we let it on, we leave it on the skin surface for a few seconds, and the heat dissipates over time. Here are some representative images that we're able to obtain from our device, and we're able to validate these temperature readings using a thermal infrared gun that we're able to obtain from our research collaborators. And here is how our algorithm detects these regions of interest. So as the device moves, and as it can accurately identify these regions of
So for the multispectral analysis, our goals were to create a multi-wavelength imaging system and to validate spatial chromophore calculation. So to do this, we took images of a reference gray card and a sample at 5 distinct wavelengths. We then normalized these images against the reference to calculate per pixel optical density values using Beer-Lambert's law. To validate this, we then compared the normal finger with an occluded finger to see if we can detect changes in blood oxygenation. And then from this, we developed spatial maps of hemoglobin, oxygenated hemoglobin, and melanin, where the top row is the normal finger and the bottom row is the occluded finger. And from our results, we see that hemoglobin increased, the oxygenated hemoglobin decreased under occlusion, and melanin remained relatively constant, confirming our device's robustness to skin tone. So for the user interface, we were able to do multispectral and thermal imaging. And we also have a longitudinal tracking system that can monitor hemoglobin and temperature changes over time. For the hardware and enclosure, we designed a PCB that integrates 8 LEDs with 2 LED drivers. And this is all housed in a compact enclosure that integrates with the Pi, our polarizers, and our 2 cameras. And this is currently what our device looks like. So a limitation that we're currently facing is uneven illumination, and we plan to fix this by adding more LEDs for more uniform illumination. And we also are facing inconsistent region of interest tracking, where we plan to use Oruko stickers to consistently align the camera to the same region. And so looking ahead, we plan to develop a mobile app to make our platform more accessible for everyone worldwide. And we also plan to shift from models to clinical testing on patients to validate our device. And so thank you, everyone. We are Ms. Cersei. I'd like to extend acknowledgments to our professors and everyone who has supported us in our project. Thank you.
So you're saying you're usually using this as a follow-up as opposed to a diagnostic tool, isn't that right?
Yes, just to determine, to ensure that the treatment that the patient is receiving is the correct treatment. And they can modify the treatment if needed, if it's not.
We are IoDetect, a device for global iodine screening. In many parts of the world, a simple nutrient deficiency can cost a child up to 10 IQ points before the age of 10, and no one even knows that it's happening. Globally, 2 billion people are iodine deficient, and 50 million of said people suffer from serious clinical symptoms. Because iodine deficiency often doesn't have any early symptoms, it often goes untreated and undetected until permanent damage, such as impaired development and thyroid disorders occur. Iodine deficiency is the leading cause of the world's preventable mental impairment worldwide. It happens in developing countries where iodized salt, which is a daily norm for us, isn't available due to various logistical, cultural, or economic factors. We're Haley, Alice, and Camille, and we're part of the Queen's Biomedical Innovation Team from Canada. And I created the idea for IoDetect last year, and we've been developing the project for the past 8 months.
There's a need for fast, affordable, and accessible iodine screening. Current testing relies on laboratory urine analysis, which is slow, expensive, and often unavailable in low-resource settings. Salt iodization programs have eliminated deficiency in developed countries since the 1940s, but 30% of the global population is still vulnerable, including Southeast Asia, Sub-Saharan Africa, and even Northern Canada. The World Health Organization recommends that nations conduct iodine screening every 5 years, but many lack the infrastructure to do so. IoDetect is designed to directly address this gap by making it easier for nations to guide effective population monitoring to better inform nutrition programs. IoDetect is a handheld point-of-care microfluidic device. A urine sample is loaded into a microfluidic chip where a chemical reaction produces a color change based on the iodine concentration, which is read by our portable device. This produces a data dashboard that governments and NGOs can directly use to inform national iodization programs. All this with no lab or technician required.
So we created 3 different categories to guide our design. For the user requirements, we focused on accessibility. We wanted the device to be something that anyone could use at a price point that made sense for the target communities. For the technical requirements, these were driven by the colorimetric reading, shaping the optical setup, as well as the microfluidic architecture. And finally, the design constraints stem from the chemistry of the reaction, dictating the materials of the chip, as well as the geometry and pressures. So our device uses the Sandel-Kolthoff reaction, which is a well-established colorimetric method to quantify iodine concentration. And in the lab, we validated the reaction using stock iodine solutions and created the calibration curve on the screen, which shows various iodine concentrations. And we measured the absorbance using our electrical system. And our electrical system showed similar measurement accuracy to a plate reader.
So now I'll walk through how we shrank the lab onto a microfluidic chip, which is made from PDMS using soft lithography. It contains serpentine mixing channels promoting mixing through passive diffusion, eliminating the need for active mixers. And syringe pumps control the flow rate of each reagent within the chip. Once mixed, they enter the optical chamber for signal reading. We used COMSOL multiphysics to validate the chip design. This confirmed uniform flow velocity with no dead zones and complete mixing before the end of each serpentine mixing channel, giving us confidence in the geometry before fabrication. Physical chip testing with colored water further confirmed effective mixing, no delamination, and no channel failure, further validating the chip design itself. So in the final device, the syringe pumps will be automated, which allows for precise reaction timing and would minimize user-based variability.
So all the components fit into the casing, as you can see here on the table. And how the device works is you open the hinged lid, insert the microfluidic chip, insert the syringes and connect the tubing to the chip, close the lid, and then answer a couple questions using the screen and buttons, and then the electrical components will do the rest. Focusing in on our electrical components, the LED is illuminated once the reaction is complete, and then a photodiode above the optical chamber of the microfluidic chip reads the result. And the software integrates a user interface screen which displays the processing time of the reaction as well as guides the user. And then the test data is uploaded to a Firebase. There's authorized users can access a secure web dashboard which allows them to continuously monitor the data being collected. This is the main output of IODetect and can be used by governments and NGOs to be able to inform their iodine nutritional programs.
So the team additionally underwent stakeholder engagement across various sectors, and that first provided feedback on our development of our device, but then also validated that our device aligns with the needs of governments and NGOs. To specifically quote Dr. Maria Anderson, who was a previous technical officer at the WHO, IODetect would be a breakthrough in global nutritional screening. In 8 months, we've successfully demonstrated proof of concept for microfluidic point-of-care device for iodine screening. Some current limitations include some of our reagents that are used, and we have not yet validated against patient samples. Our next steps address these, specifically doing pilot testing with Canadian labs in Northern Canada. To conclude, IODetect turns global iodine screening from a lab-based challenge into a point-of-care solution. With IODetect, we can prevent millions of cases of cognitive impairment before they start. Thank you.
So is there a known fixed relationship of iodine concentration in urine and blood?
Ours specifically focuses on urine, but yeah, you can also detect iodine in blood.
Right, I'm just wondering, I mean, you're talking about body levels of iodine. I mean, I'm just wondering, is there a known correlation between those two values, blood levels and urine levels, or does it?
Yeah.
Is there a discrepancy, between high and low and what's secreted and that sort of stuff?
Yeah, I'm not completely sure about between urine and blood since we were focusing just on urine, but this is more of a screening tool rather than a diagnostic tool because within iodine, like urine testing, it depends on how hydrated you are, what you just ate. So it's more of an overall population screening tool to be able to develop or see the median concentration in a specific area.
Can you speak to once it's identified that somebody has iodine deficiency, if there's available treatments for that in these regions that don't have the resources like iodinized salt?
There are specific treatments within clinics, but this device is more for a widespread determination of where to put more iodized salt. Currently, with the data available, people just collect an average for the country, so you're not able to see within the country geographical regions that are more iodine deficient or iodine excess. Specifically, for example, in Nepal, they introduced an iodization program, and then the pendulum swung the other way, and there's regions of the country that are very iodine excess, and then regions of the country that are still iodine deficient. So it's more of a tool for helping governments know where to put those salt iodizations, because that is the most successful measure for preventing iodine deficiency.
I had a quick question on the videos that you showed. Your microfluidic device had a number of bubbles. How does that impact your test results?
So bubbles are kind of a common problem that we see in microfluidics. So specifically in the video, there was that large bubble in the incubation chamber, and this is a previous design. That's part of the reason we got rid of the design. But that's also some of the next steps are looking into different ways to mitigate the effects of bubbles, and if there are bubbles, to make sure that the channels don't delaminate or fail and the device can still function as intended.
Yeah, specifically with this example too, this was external syringe pumps that we turned on manually. So just from human error, there was a delay in the timing of that, which introduced a lot of bubbles. But in our device, there's syringe pumps that are automated that start at the same time. And from some of our stakeholder impact from Queens, we've gotten some good ideas on things we can incorporate in future iterations for filtering out bubbles, which we're looking into.
on where a woman lives, endometrial cancer is either a highly treatable condition or a fatal diagnosis. In many low-resource settings, the greatest barrier is not a lack of medical knowledge, but rather a lack of clinicians trained to screen early. As Team Agile, we have found that endometrial cancer is becoming one of the most common gynecologic cancers worldwide, with cases exceeding 600,000 within 20 years. Yet the standard screening procedure and endometrial biopsy remains highly inaccessible. When we mapped disease burden across low and middle income countries, the need became even clearer, as many of these regions lacked access to an OBGYN. This points to a crucial opportunity for task shifting to train nurses, primary care physicians, and frontline providers with the skills to perform earlier screening closer to patients. However, performing an endometrial biopsy is not simple, as providers must rely on tactile feedback to know where they are in the anatomy, as well as be familiar with the tool in order to take an accurate sample for pathology. Despite this challenge, training models are limited, as commercially available models can cost more than $6,000, while lower cost options rely on fruit or animal tissue for realism, but that is not as accurate. This leads us to the Lucia, which is a successful Rice 360 trainer for cervical cancer screening that is available globally and used in training programs. However, it lacks a uterus model and a fully penetrable cervix. Hence, our goal is to design a uterine attachment for the Lucia that is anatomically accurate in shape and feel, user-friendly, and accessible in low-resource settings globally.
So to reach this objective, we worked with our clients at MD Anderson and our Rice 360 mentors to develop 5 key design criteria that would evaluate the success of our model. The first, it had to be realistic and feel like the actual procedure, scoring at least a 4 out of 5 on Likert-style realism surveys. Second, easy to use, allowing trainers to reset the model in under 3 minutes. Third, compatible with the standard endometrial pipelle, allowing trainees to collect a full sample. Fourth, under $20 to reach a wide variety of clinical settings. And finally, durable, allowing it to cycle through at least 100 trainees before requiring additional maintenance to account for the high volume training settings in which it was designed. And again, all of these criteria have been justified according to our stakeholder needs. This is our current training model design as it's attached to the existing Lucia. It consists of a main silicone uterus enclosed in a hard plastic outer casing. And inside of that uterus, we fill it with our synthetic endometrial tissue sample, which I'll talk more about later. On the front, we have our penetrable cervix that attaches and aligns with the Lucia's vaginal canal. And finally, the uterus can be opened and closed via a lid with magnets, and the magnets are essential for creating a vacuum seal to make it feel like one continuous muscle. That sample that I was talking about, we tested and evaluated a wide variety of materials with our clinical specialists to see what would mimic the mucus heterogeneous-like texture of the endometrial tissue, and we found that a mixture of hair gel, chia seeds, and food dye actually proved to be the most realistic. It also was able to fill the pipelle completely without getting stuck, and it's easily sourced and transported abroad, which makes it accessible for a wide variety of settings. Another key component to this procedure is that doctors need to feel the change in resistance at the beginning and the end of the cervix when they're passing the tool. And so we made a way to make those resistance points replaceable inside of our cervix as they start to wear, so that it increases our realism and durability while also minimizing our cost per use. This is our current physical prototype. It costs about $17 to make, and we've been working on it for about the last year, and it's highly realistic.
Okay, so after conducting initial iterations and testing with our clinical mentors for this model, we officially deployed it last summer. We've tested with over 40 clinicians in Houston, Kenya, the Dominican Republic, and now Mozambique. We used a Likert-style survey. We assessed for anatomical accuracy, cultural feedback, and usability. As you can see, we got really strong feedback. We have a 4.9 for effectiveness in training and a 4.6 for anatomical realism. And Obi even told me she wishes she had this model when she was learning how to do a biopsy, and that really emphasizes the training gap that we're filling. A limitation that we've seen is that our model does not yet design for tenaculum training, which is a tool used to reposition the cervix, and this is going to be part of our future iterations. And for next steps, we're doing additional field testing to prepare for publication and optimizing for manufacturing with Vice 360's partners in Malawi. In conclusion, our EMB trainer is already improving training access because it has been validated across diverse cultural settings. Most importantly, Agile is not just a device to be deployed, it is a capacity building tool that has been designed in collaboration with the communities we aim to serve. Because together, we are turning training into access, and access means better outcomes. Thank you.
I understand the human factors component. So when you're doing the questioning about usability and anatomical realness, but what is the end result? Is it I understand it's to train physicians to take endometrial biopsies, but are a bunch of physicians trying this and failing, or are they afraid to try it because they're not appropriately trained? What's that endpoint that's going to be meaningful for you in deploying this?
So the question is asking about the end result of training with the model. For that, I would say the main problem is the lack of specialized physicians. So currently in low resource settings, it's considered a specialized procedure and a very limited number of OBs know how to do it. And our aim is that if they are able to train the nurses who work with them and the community health workers who work with them, they can screen patients earlier. And so it is a hard thing to diagnose because you need tactile feedback. And so there's very little external feedback that tells you how to do it. You need to know how to navigate the anatomy, which you can't see because it's all inside the body. And so if an experienced OB can teach you how to do it through a training model, it means when you do it on a patient, you're not doing it for the first time and then messing up and they don't have to come back to the clinic.
One of the risks of doing an endometrial biopsy is uterine perforation. Does your device allow for perforation as an adverse outcome?
Yes, thank you for talking about this, actually. I think Valerie is our resident expert.
Yeah, so the question is whether our model accounts for uterine perforation. And what we've done is we added the fundus, right? The back part of the uterus is very cushioned. So when you are putting the tool, the pipelle, through the model, you'll be feeling that feedback, that resistance that you can't go any further. And that's supposed to train any of the physicians to when to stop moving the tool through. But of course, I do know that when a patient is very inflamed, the fundus is easier to perforate. But when you just have this hand kind of muscle memory, that's kind of the goal we're trying to get out of this training model with that resistance.
Before we begin, I'd like everyone to take off their glasses. So for those of you without glasses, this is what they see. It's kind of blurry, isn't it? Would you want to see the rest of the slides like this, or even, the rest of your life? But for a billion people out there, this is not just a demo. This is the reality every day. You guys can put on your glasses now. Let me give you something that's not so blurry. 2.2 billion. This is the number of people around the world that have some sort of visual impairment, and of this, over 1 billion people lack the access and the resources to correct their vision.
Vision is the foundation for safety, for education, for income, and ultimately for a longer, healthier life. These impacts are profound. Let's take a look at the data here. Dropout rates exceed 44%, as well as an annual productivity loss of over $400 billion. Additionally, anxiety and depression rates increase by 5 times. As we can see, untreated visual impairment affects every aspect of a person's life.
Getting the glasses is the easy part. The hard part is actually getting the prescription to make those glasses. The device optometrists use to get your prescription is called the 4-opter. So on the left here, we see the traditional 4-opter, which manually switches between lenses until we find the one that works. On the right, we see a digital 4-opter, which does this automatically. Both of these cover a wide range of prescriptions, use subjective refraction to get the clarity of the lens, and are efficient and widely used by optometrists.
But with such great technology, why do so many people around the world still lack the proper eye care today? To answer this question, we took a direct trip to one of the poorest regions in the world, Hazan, Vietnam. With this, we decided that we would travel in this area, and we focused ourselves 6 hours from the capital. And this is where lack of medical resources lie. With this, we drove an additional 8 hours to reach this peak to focus on this community right here. As we can see, they don't own much. This single building is what houses their medical centers, schools, and communities all under one single roof. The health disparities between the US and these rural communities are stark, and we aim to bridge this access gap, which is challenging. From our travels, we noticed that the clear vision to a bright future hides behind this costly and heavy paywall that is the 4-opter.
So, given the patient populations that we aim to address, such as those in Hazong, Vietnam, we've come up and envisioned a solution that is easy to use, low cost, lightweight, and portable. We went from engineering a solution that isn't from $22,000, not to $2,000, not to $1,000, but to $100 and a payload of 2 pounds. This is Foroviz, a mechanical liquid lens phoropter that's affordable and easy to use for any community. As you can see here, Foroviz uses 2 different lenses. It uses a spherical lens that's able to measure the nearsightedness and farsightedness of a person's prescription, as well as a cylindrical lens that measures the astigmatism. Instead of the 30 mechanical lenses that a traditional phoropter uses, Foroviz is different by only using these 3 lenses. Another way Foroviz is accessible is that we use common plastics and materials such as PETG plastics and PLA plastics that's easy to find and accessible in all regions. Foroviz is also easy to manufacture using common and traditional 3D printing techniques. Now, the way Foroviz works is that we take a syringe and inject liquid into a flexible PDMS membrane, which then alters the curvature of the lens, which then in turn alters the refractive index, which then changes the prescription. Now, the big question is this: does our liquid lens device give us the optical accuracy we need? Now, the short answer is yes. We tested Foroviz on ourselves and were able to retain 100% accuracy based on our own prescriptions. But this subjective self-testing isn't nearly enough for the rigor of real-world efficacy, which is why it led us to create simulations and models as a baseline for future testing. Mathematical accuracy is meaningless if there's no accessibility. As you can see here, 1 unit of Foroviz costs $100, which includes $70 worth of manufacturing and shipping costs. This leaves us with a gross profit of $30. Now, to get Foroviz into the hands of providers, we have a clear and concise roadmap. Following the feedback that we get from this design challenge, we'll use that to finalize our minimum viable product, which will then help us create our clinical trials to then finally go into government approvals and deployment.
So how does vision correction actually change lives? So based off some research studies that they've done in China, we saw that in rural populations, children had a 9% increase in aspirations to attend school. This isn't just seeing clearer, it's dreaming bigger and aspiring higher. In addition, we saw that in elderly aging populations that have never experienced any sort of vision correction in their life, after providing it, there's a 31.6% increase in productivity, reversing decades of productivity loss instantly. In addition, we saw that in the underperforming students, specifically in the lower third of math, we saw a 10 to 24 percentile point increase immediately and sustainably. All of this shows how just changing one simple thing can alter our lives, our fates, our trajectories. And that is vision. All of these people could finally see. Foroviz doesn't give you the glasses, but gives you the prescription that can help you get the right pair of glasses to suit your needs. But despite this, so many people around the world still see this image. But it doesn't have to be that way. That's why we here at Foroviz believe in a clear vision for a bright future. Thank you, guys.
Can you tell us more about your preliminary results and kind of where you're at in the process?
Yeah, for sure. So here at Foroviz, we've designed and we've sort of been testing it on ourselves, relatively new. We haven't really gone into the clinical trials phase, but speaking with Dr. Reed over here during the poster presentation, he was also advising different ways to kind of get like a calibration or a test, and so we were kind of thinking of implementing that after. But again, like we haven't gone into like the full clinical trials, which will come after this presentation, after this design competition. We finalize our minimum viable product, and then are able to actually go into that phase.
Just adding on to that real quick, since we are a non-invasive device, our FDA and MDR regulation is class 1, which means that the regulation process is pretty lax for us, so we should be able to get into the market and start testing a lot faster and sooner.
The question just occurs to me, you're in they can't afford the usual, what we have, but they can afford to have lenses ground to meet these prescriptions? This is trying to understand the usefulness of your device, because it doesn't do any good if you can't get the glasses.
Of course. So our goal is to actually partner with these NGOs that like Unite for Sight, the Himalayan Craft Mission, and stuff like that, that actually make these glasses for very cheap prices. But the issue they face is actually getting the diagnosis for these prescriptions because, the bulky phoropter is too hard to take to these locations. So our goal is to, sell these to these nonprofits and, end users that can actually use these like in these low-income regions instead of to the patient or to the patients directly. So it would be used as a benefiting tool to help them out.
I think it's really cool that you just made this on your own instead of like being prompted by a class. So that's awesome. I wanted to ask about translating it sounds like the volume of liquid is what translates into a prescription. Is that correct? And have you done any error testing? And can you just talk about that process of how you get a number and then how you validate that number for a prescription?
Yeah. So we have like the amount of liquid in the syringe that we push or pull that into this like PDMS membrane. And that's sort of like, we have like, based on our testing and our testing on ourselves and the simulations, it correlates to like a number on like a diopter or a number on the actual phoropter, which then is able to like give a prescription. So it's just sort of like a correlative effect based on like a relationship that we've established through like the testing.
Right now, it's a little curved right now because the PDMS can always change over time. But there seems to be a direct, somewhat positive linear correlation right now. But once we start doing some more testing and actually compare it using actual lenses that we buy off like Lenscard and stuff, we can actually get like a proper linear range of stuff.
So like 60% of newborns, I was born with jaundice, and as a white baby born in a developed nation, I was diagnosed accurately, treated with, sorry about that, and and sent home with no complications whatsoever. So the issue is that a lot of other babies that are born in other areas of the world don't get this same treatment, and their outcomes are very different, although they're preventable. This can be seen by jaundice is still in the top 10 of newborn fatalities in developing parts of the world. And my name's Spiro, along with Ben and Nicholas. We came up with Bluebill, which is a handheld, non-invasive device that estimates bilirubin and it doesn't use any needles or sorry about that. Yeah.
So currently there's two clinically used diagnostic methods. Total serum bilirubin is the gold standard, but it involves a heel prick, which is both invasive and painful for the infant, and also can contribute to iatrogenic anemia. On top of this, it increases the risk of infections and bloodborne pathogen transmission and relies on single-use kits that also most oftenly need, laboratory infrastructure. The only non-invasive clinically used diagnostic is the transcutaneous bilirubinometer, which gives you the TCB reading. These suffer from diagnostic bias related both to skin pigmentation, but also to skin thickness. So premature infants have thinner skin affecting the path length and then the accuracy of the diagnostic. Additionally, they cannot be used over the course of phototherapy because the deviation between TCB and the total serum grows as you apply the UV light. So ultimately, in these LMIC settings, these are unaffordable, expensive supplementary tools and are therefore not significantly used.
So now I'd like to go over the design rationale, and how I want to do that is I actually want to talk about our design requirements over our core themes. And because we are working with babies, our first priority is safety, and we determined our safety theme by using the least invasive measurement tool that we thought of, which is through optics. And because we were using optics, we also wanted to make sure that the specific light wavelengths that we're using don't have the intensity of that light at that specific wavelength doesn't damage the tissue that it's reacting with. And also, this directly ties, the fact that we're using optics directly ties to the fact that our equity theme, and we want to make sure that our device is used in is able to be used with patients of all demographics, regardless of their demographic, and we're doing that by actually measuring the bilirubin content through the sclera of the eye, and we determined that, and we decided to do that because we found measurements with the bilirubin content in the sclera of the eye is the most consistent across different demographics. Also, we wanted, another theme of ours is we want to make sure it's accurate and usable in the actual hospital settings, and we determined that by actually making sure our accuracy is within 2 milligrams per deciliter of, we could determine the bilirubin content within 2 milligrams per deciliter, and the diagnostic method should take around 30 seconds or take under 30 seconds, and also because we're working with less equitable populations, we want to make sure our device is portable and reusable. This is our actual device over here, and it uses controlled light and reflective optics to measure bilirubin content, and it has an ergonomic grip, a measurement trigger, and OLED display. And we determined these designs to make it as easy as possible to use for nurses, and require minimal training. And the advantages of this is that it's obviously non-invasive, it's non-skin tone based, it's usable with the current phototherapy treatments, and reusable, cheap per unit cost.
So moving on to our benchtop testing, we have shown that this wavelength absorbance correlates with hypothetical bilirubin concentration. So we did benchtop testing by casting silicone dyes, and we modeled the full clinical range of jaundice based on published color cards, where we took those hex codes, matched different levels of pigment in our gels with a spectrophotometer, and then took measurements with our prototype device. We've found great consistency between measurements, and our calibration curve was generally linear, with an R-squared value of 0.976. So currently we're limited by the fidelity of these models. The sclera of the eye has high collagen content, which creates light scattering. That's what gives it the white color. Our model currently, with the silicone alone plus the pigment, doesn't capture this. So we're looking at certain additives like titanium oxide to increase the scattering. Hemoglobin interference is also an issue, which we like because of the vasculature and scleral thickness. Ours are uniform, but it varies patient to patient. So we plan to improve our models in this benchtop testing by mimicking the light scattering with these additives, introducing redness to the model in a network-like configuration to mimic the vascularity, and then refining our hardware and algorithm to produce a minimum viable prototype in partnership with a small batch medical device manufacturer. With this MVP in place, we will proceed to a pilot trial where we take paired serum bilirubin measurements with our transscleral and validate this in a diverse patient group. Thank you.
Does Overcome's skin tone impact on measuring transcutaneous bilirubin? Can you share more about how that technology overcomes the skin tone issue?
Yes. So by taking measurements from the eye white, we don't suffer from the same diagnostic bias related to the skin pigmentation itself. We're also using a multi-wavelength approach to account for the hemoglobin interference. So different retinal conditions can cause, ruptured blood vessels and things in the eyes, which could interfere with the absorbance for our primary wavelength for bilirubin. And then we're also using a third wavelength near infrared to account for the path length. So anatomical variations will also be normalized.
Hello, everyone. We are honored to introduce to you the Amai postpartum monitoring device. To start, we want you to think about your next 24 to 48 hours. Maybe you're planning on visiting the city, or maybe just getting some rest. Now imagine a different reality. For women who have just given birth, these same 24 to 48 hours are extremely dangerous. In many low-resource setting maternity wards, once a baby is born, attention quickly shifts away from the mother. After hours of labor, she is left exhausted and vulnerable to serious complications that can develop quietly. With few staff and overcrowded conditions, these warning signs are easily missed. Every day, over 700 women die from preventable pregnancy-related complications, and over 90% of those occur in low-resource settings. That is why there is an urgent need to improve care for mothers when they need it most.
We are focused on one mission: preventing maternal mortality through expanded access to postpartum clinical monitoring. This is why our partnership with the Otakaraka Foundation in Malawi has been so important. From leadership of Ida Poliwa Mwango and the clinical insight of Dr. Tem Mwango, we have gained a firsthand understanding of the realities inside these postpartum wards. A study from The Lancet states that hemorrhage, sepsis, and hypertensive disorders are 3 of the leading causes of postpartum maternal mortality. This has directly informed our design rationale, as changes in temperature, blood pressure, and heart rate are 3 of the earliest signs that these complications are taking hold. It has also become clear that our device must be affordable, durable for continuous use, intuitive for minimally trained users, and capable of providing clear alerts.
We are developing AMAI, which stands for Advanced Maternal Alert and Intervention, which also means Mother in Chichewa, where our OTK partners serve. Our system is a wearable forehead sensor that allows for timely physiological monitoring. Our end goal is a central monitoring system and mobile app that allows one clinician to monitor multiple patients at once. Our prototype integrates a PPG sensor, infrared temperature sensor, and microcontroller in a TPU printed housing attached to a headband made from local Chitinji fabric. To better understand our device, we must first look at how blood pressure is currently measured. The gold standard is an inflatable cuff, but it requires manual measurement, is uncomfortable, and only allows for intermittent monitoring. That is why our key innovation is a cuffless blood pressure estimation using photoplethysmography to track changes in blood volume. This is a global need highlighted by recent calls for cuffless blood pressure monitoring from the Gates Foundation. From our signal, we will be extracting 4 key parameters: heart rate, which we find by tracking time between beats; DC component, which represents the baseline blood volume; AC amplitude, or the pulsatile flow; and pulsatility index, which is a ratio of AC to DC. Literature shows that pulsatility index is inversely related to blood pressure. As blood pressure increases, vessels constrict, pulse lowers, and pulsatility index decreases.
We use this relationship to build our calibration model. Currently, we are collecting cuff measurements alongside PPG data and extracting these 4 parameters to help build our model. In addition to blood pressure, we also have heart rate. We have validated heart rate against reference devices across multiple trials, and all readings stayed within the clinical range. Finally, for temperature, we have compared our calibrated infrared sensor to clinical-grade thermometers across multiple trials, and all readings also stayed within range. Shown here is our simulated interface that allows clinicians to set custom thresholds, and as real-time data is being streamed in, any abnormal values will be flagged with color indicators and alerts.
Our testing has also further clarified our system's current capabilities and its remaining constraints. On the success side, our device can be locally manufactured and sustained, and our heart rate and temperature estimations are currently performing well. However, we rely heavily on post-processing, and for reliable measurements, the patient must be resting in a supine position. These help guide our next steps, as we're currently in the verification process and plan to move towards CE marking for international deployment by 2027.
In closing, this is an urgent and ongoing crisis. During the time of this presentation, 3 women will die from preventable pregnancy-related complication. The most critical window is the first 48 hours after delivery, yet in many low-resource settings, women are left unmonitored during this time. The AMAI is designed to close this gap by providing affordable, automated vital sign monitoring tailored specifically for postpartum wards in low-resource settings. Thank you for your time and for being part of the effort to make postpartum care safer worldwide.
Could this be used to measure preeclampsia?
Yes, absolutely. Great question.
About 2 years ago, I was interested in using the various Fitbits on the market, wearable devices for measuring temperatures. And I found out that every single wearable device I could find on the market was inaccurate. If you took whatever it says and actually you measure it manually or with a proper thermometer from a pharmacy, it was wrong. So could you give me some idea of your understanding of these wearable devices and why you feel your device is different from most of what we see on the market?
So our device is different than currently available PPG cuffless measurements because our device is first suited for pregnant women, which most devices are not. Along with that, our device costs around $45, which is a fraction of some of these other devices as well.
Also, to add on that, most of the Fitbits currently, they're all on the wrist. Most of these, your wrist position based in relation to your heart is different based on whenever you move your arms. So in our form factor, we chose the forehead. And in our case, the forehead remains in the same position in relation to the heart almost every time. So that helps eliminate any motion artifact, any other factors that would mess with our signal.
Could you use this, or have you thought about perhaps using it to detect postpartum hemorrhage?
Postpartum hemorrhage is one of the key features, or not features, one of the physiological things that we're looking for. We understand that postpartum hemorrhaging, it can happen really, really quickly. And that's when our blood pressure would change very, very quickly as well. So we are using blood pressure to help identify physiological signs that are associated with hemorrhage.
Quickly to add on to that, not only are we trying to display numbers for heart rate and blood pressure and temperature, we're also detecting trends. So when there's a quick spike or trend, quick increase, we're going to notify the clinician to put the power in their hands so they can make a decision and be more informed right away.
So wonderful presentation there. You were talking about looking at signals that can have big spikes in them, and you have a wearable. I've been working on wearables for a while, and I'm very well aware that people's motion artifacts, contact, how are you handling the filtering of the data to be able to handle filtering out movement artifacts and details like that from something like a rapid blood pressure drop?
So in our device, we're currently using a running DC average and exponential moving average that'll help smooth our signal and allow us to get that average DC baseline.
Hi, I'm Zach Hertzman. This is my partner, Will Acree, and we designed an affordable cardiac ultrasound phantom. Now, what a phantom is a training tool used for point-of-care ultrasound that when you probe it, the anatomy of it reflects that of a human. And our design is 3 parts. It's the phantom itself, the instructions to make it along with links, and the open source files used for the 3D printable parts that are necessary in creating it.
So the design goal or the global health challenge that we're trying to address is that in resource limited areas, ultrasound is, especially recently, widely accessible and widely used because its cost has dropped significantly in recent years. It's also widely used just because radiological imaging is not very common because it's very expensive. However, the educational resources to go along with ultrasound are not as common, and that's the gap we're trying to bridge, right? 45% of healthcare workers say that they are not experts in ultrasound, and you would want your doctor to have those qualities.
With that in mind, we broke our design goals down to the 4 categories shown. And the most important two to us have been the cost and manufacturability, as those are the most pressing issues in resource-limited areas. However, we have to keep that balance with anatomical accuracy as we want training to be reflective of the real environment they'll be facing. Right now, cost, we have it at around $92 per unit, but considering you have to buy items in bulk, that comes out to around $120. And everything can be made in a kitchen, which is something that I know everyone has, which is one of the big benefits of our design. Oh yeah, to put that into perspective with things on the market, ours is just 1.8% the price. Or if you're more of a visual person, you can make over 54 of our Phantoms for the price of a single commercial unit. Ours also features realistic rib shadowing, which is what happens with ultrasound. When you go over a rib, it blocks your view, which makes the students that will be training with it, they must understand their positioning of the probe, which is something that's not common in many of the commercial models. And to our knowledge, there's nothing on the market below $4,000, nor other affordable innovations that truly last.
Yeah, so for the design solution that we came up with, it uses 3 materials. It uses agar gel, psyllium husk, which we call Metamucil. It's just a common fiber supplement, and gel wax. You use gel wax to make everything except the walls of the heart. So the first steps you can do in parallel. You simply put gel wax in the encasement, which is the top right, and then you fill the walls of the heart and the heart molds in the bottom right with agar gel and Metamucil. And then you simply stick the 2 heart halves together, put those in the encasement, let it cool, and then demold the next morning. And then these are the views we have. So your 4 common heart views. On the top is an actual heart, and on the bottom are the views that we have. 2 things to note is in the personal long axis view, it looks slightly different on ours than the real view on the top, and that's because we don't have an aorta, simply because it's really hard to make and it's complex due to molding. And then in the personal short axis view, it's in our view, you can see it well, the 2 white dots on top of each other in the left ventricle, those are papillary muscles, which are important things that we decided to add as they're important wayfinding devices when you're trying to orient yourself in the heart.
We originally made our design for the Duke Physician Assistant School, and we attended biweekly point of care ultrasound training sessions that they hosted. And with that, we were able to get a lot of constructive feedback from them. Much of our iteration has been on their feedback, and that's been helpful. We're looking to expand more into rural America or low to middle income countries, and we're going to be able to do that with our open source design that anyone can access and make with just a 3D printer on hand. If a 3D printer is not accessible, you can also order those parts too very cheaply, as there's many 3D printing websites that offer that. And we've had many successes, but there are a few things we need to change. We're pretty far into the design process, and we want to shift our outreach more or our focus more towards outreach to receive more constructive feedback from a bigger population, as well as just get the use of our design out there. But before we do that, we want to fix some issues in manufacturing. It currently takes a long time due to low heat resistance of our materials, and we found coatings such as Flex Seal, which I'm sure many of you have heard of, that are more heat resistant and can prevent that issue. And we're also running into issues with design complexity, as Will mentioned, with the aorta. As we make it more complex, it's obviously harder to replicate for the people we want to use it the most.
Yeah, and coming to future plans, we have 2 types of plans. We have design related on the bottom and non-design related on the top. The first thing we want to do is decrease 3D printing resources, simply because it takes about 70 hours to print all the requirements necessary. The encasement's pretty big. We currently have it down to 60 hours but we want to continue to lower that because we think that that's a constraint. We also want to add modularity for different conditions, right? This is something that really makes our Phantom extremely valuable when you can, because on a normal person you can't simulate like obesity or other conditions, and something that we want to be able to do. And then the last design related goal we have is we want to be able to create other organs like the shoulders and lungs, because we believe that that's what would come next after a cardiac model. For non-design related goals, we want to open source our designs. We actually have open sourced version 1, just not version 2 yet. We're still working on that and making sure we fine tune it so that it's good to go when we do. And then we want to complete an educational study to get some qualitative results. We already have secured a grant for this, and we plan to do it next semester. And thank you, we're ready for questions. And I want to apologize, our slides kind of blew up when we sent them. Some of the formatting was pretty off.
Why not just use live models? Why not just partner with somebody and do the evaluation on their chest?
One of the biggest things about our model that we find pretty fascinating is that you're able to do, one of the big things is ultrasound guided injections, especially with things like pericardial effusion, where there's fluid around the heart that they need to drain. And that's something you can't practice on a normal human. With our design, you can practice that. And one of the issues becomes air inside of the models. With current commercial models, once you do that, it's like a one-time use thing. There's then a hole there anytime you ultrasound it. Ours, you can actually use a heat gun on it, and it'll self-heal itself due to just the properties of gel wax. Gel wax is commonly used in like homemade candles, if that gives you guys a reference for what it is.
Yeah, I mean, there's also just some conditions that you'd want to be able to get experience on ultrasounding. And also just, right, you don't want your friend to have to sit there for 2 hours while you're trying to learn how to ultrasound. And on top of that, there is a pretty big market for cardiac phantoms. Right, this started because we got a request from a client to make one. And we've also seen significant like desire for this from like other universities. So we would assume that there's probably the same desire for educational resources in resource-limited areas.
And one final thing for that is that students at our PA school had commented on like the clarity of it being helpful and them actually understanding like what they're orienting towards, and like you're able to see that the apex of the heart is over here, so it makes more sense for your apical 4-chamber view.
Hey guys, as you point out, air is a big enemy in ultrasound, and I'm just wondering, have you thought about incorporating lung simulations in proximity to your heart model? I mean, because your window narrows significantly once somebody's maybe hyperinflated lungs, that sort of stuff.
Yeah, this was something that was brought to us pretty recently, actually, that somebody wanted to see. And it's definitely something we plan on doing in the future. It's probably like the next step in really changing it, because we know that adds a lot, and you can also add more, just like heart and lungs are very connected, obviously, so you can do kind of like procedures and things that come with both of those.
One of the most difficult things about ultrasound is, especially the heart, is that it's moving a lot. And I was wondering if you thought about incorporating motion into your model.
We have had comments about that, especially from the students. And currently, like our biggest point is affordability, replicability, and we don't see that. Adding fluid is something we've looked at, but having any sort of movement would pretty much be beyond the scope of the affordability and replicability aspects of it.